So, good afternoon. We open this session on the practical approach to aortic valve repair. We hope to go through all the aspects of this fascinating way of repairing the aortic valve. I call on the podium the first speaker, Dr. Johannes Sjögren from Lund, Sweden. They will speak about the guideline, other clear on indication and timing. Please.
Thank you, Rogero. Thank you, Rafa. Dear colleagues, I have no conflicts of interest. You're important, and you're all here today because you share one common goal. You want what's best for your patient. And how do you achieve that? You look at the data, you study books, you read our journals, but sometimes it's easy to get lost. This is how I feel sometimes when I look at the data. There's information everywhere. So what do you do then? Because you still want to achieve this goal. You want the best results for your patient. I know what I do. I turn to the guidelines. And this is what I recommend you to do as well. Go to the guidelines and then let them guide you. I have been doing heart valve research for 20 years. And I was very fortunate to be asked to participate and be a member of the task force producing the latest guidelines. And this is the ESC and EACTS guidelines for valvular heart disease. In this task force, there are very inspiring people. They were surrounding me and inspiring me. There are people like Volkmar from Berlin. There were Michele from San Raffaele here in Milan. Very well known in aortic valve repair, Emmanuel, and Thomas Walter from Frankfurt, and Olaf from London. And you know, this task force and the members here, they screen all the data, so you don't have to do all the work. Screen the data, we discuss the findings, and we try to reach a consensus. Because often there's no randomized trial, but it's a consensus of experts. You all have read the guidelines, and you know the European guidelines have a strict format when you produce them. There are classes of recommendations, and the class 1 for what we recommend, class 2 what should be considered or may be considered, and then there's the class 3, not recommended. And besides that, there's also level of evidence. And when it comes to cardiac surgery, most of these evidences are the level C. It's a consensus of the opinion of experts or small studies, retrospective studies, and registries. But as I said, there's a lot of hours, say hundreds, maybe thousands of hours to produce a new guideline. So you can lean on that when you want to choose the procedure, if it's going to be aortic valve repair or aortic valve replacement. And if we go into the guidelines, if we look what's written when it comes to aortic regurgitation then, because this is a session about aortic valve repair. Well, so far the standard procedure is aortic valve replacement. But as you can see in the guidelines, there are a recommendation, 1C, for a heart team discussion is recommended in selected patients in whom aortic valve repair may be a feasible alternative to valve replacement. And what kind of patient is that, the feasible patient? Well, it's a patient with a pliable, non-calcified tricuspid or bicuspid valve with a type A or type 2 mechanism of aortic regurgitation. So we have actually two major situations in our patient when we can consider aortic valve repair, and that's aortic root enlargement and the cusp prolapse. This is maybe one of the most important things to remember from this talk. So, if you look at the 2017 guidelines that was released last year, then we had a new recommendation also, and that's that aortic valve repair is now recommended in young patients with aortic root dilatation and tricuspid aortic valve when performed by experienced surgeons. I say this recommendation is based on the tremendous work that has been done by colleagues around us, experts in the field. We have Schaefer's group, we have the group from Brussels with Professor El Khoury, and we have also Emmanuel in Paris. And what we have said is that in experienced centers, valve repair yield good long-term results with low rates of valve-related events, as well as a better quality of life. So this is the published data, and this is what we based our guidelines on. But are the guidelines perfect then? Of course not. Very few things are perfect. And there are gaps in evidence. And especially what we need is to refine the criteria for decision-making between aortic valve replacement and aortic valve repair. Here we need more data, and we're depending on you as a community to produce more data and to publish data. This is how we can improve and update the surgical guidelines. So, I will end up this lecture with the key points from the new valvular heart disease guidelines. When it comes to aortic valve repair, the choice of the surgical procedure should be adapted to, first, the experience of the team. What do you have? What kind of members do we have? What's the knowledge? Are they as good as in Brussels? We're going to hear from our colleague about the echo, because the echo is very important when you do valve repair, as you know. And how's the intensive care? So you have to decide what's the experience of my team. Then, of course, look at the anatomy, the root aneurysm and the cusps. Is it suitable? And also, what about the patient's anticoagulation? That could be a very informative variable in this equation. So this is what the guideline says. The guidelines can guide you as a surgeon, but of course, the clinical judgment. This is very important, of course. This is where you decide whether a patient's going to have a replacement or a repair. You look at the patient and you decide what are the patient's life expectancy and the expected quality of life. That's up to you. That's a great responsibility, but that's why we're here today, because we want the best for our patient. Thank you very much.
Thank you so much, Johan. Very straight to the point presentation and very clear. Can I ask you a question? We have 5 minutes. You've shown some gaps in evidence. If you were to decide what study, one study that we would like to have, would be nice to have, with regards to this subject? What would it be?
The problem is that those kind of studies we usually want to have to decide and to give us the answer as surgeons are really hard to perform, because usually it's, you know, lack of money and the numbers. So I cannot really answer with a really straight answer, unfortunately, because there's an inborn problem with designing studies, and also, like when we look at the data and we produced the guidelines, it's more of a sum up. You bring a lot of indications together, and then you can say this, here we have it. So,
Ruggiero, would you have a study that you would like to do?
There are many studies I would like to do, but at the moment I want to ask a question just for you, just to have your impression. If you see a patient, let's say, with the pure aortic insufficiency, what would be your percentage of repairing in good hand as compared to the general surgical community? What you will see? What is perception? Just to understand the penetration of this technique into the surgical community.
Well, I think you have the question there, because you're a very experienced surgeon in this kind of situation. So I'd say when you have an experience center, you have really good data. I know from Brussels, you have a echocardiography and a cardiologist here. How often do you see severe leakage? How often do you have to convert from where you think this is going to be a good repair and then to convert to a valve?
It's very rare.
Do you see that?
Well, it depends on the expertise of the surgeon, of course. A good analysis of the valve before that can help you. But, well, conversion is very rare in our group.
Yeah.
So it's...
So yes, because the point I want to make is nowadays, regardless if the valve is tricuspid or bicuspid, the pure aortic insufficiency, in some places you can achieve very high percentage, almost 90–95% of repair. But really, in the normal life, this probably doesn't happen, and it will be much lower in the general population. That's why the reason of this meeting are just to increase the knowledge and to broaden the expertise to other people. Thank you.
Thank you.
Okay, so next speaker, we are very lucky to have Dr. Michel van Dijk. He's an anesthesiologist in cardiac and vascular surgery, and he's the one in charge of the echocardiography in the operating theater of the group in Brussels. And he will give us his views as an expert on how the echocardiography can help and what parts of echocardiography are important to the surgeon. Michel, thank you.
Thank you, Mr. Chairman, for this kind introduction. And dear colleagues, in the title of my lecture, it was the word accurate indication. So first I have to declare I don't have any conflict of interest. And accuracy is a word that's sometimes hard to apprehend, and it means to be as close as possible to the true value, to the true aspect of the valve. And during this next 15 minutes, I will try to convince you that when dealing with echocardiographic analysis of the mechanism of aortic insufficiency, in order to guide a surgical repair, accuracy means using 3D echo. And let's start from type 1. You've heard that type 1 cause of aortic insufficiency is due to aortic root enlargement. It can be at any level of the aortic root, and we distinguish between type 1A, B, and C. And you've heard about guidelines when we have to decide if we need to replace the aortic root. And therefore, we need some measurements, and these measurements will be performed at various levels, at the level of the VHA, at the level of the aortic annulus, the sinuses of Valsalva, the STJ, and the ascending aorta. And when we as echocardiographer, we perform these measurements, we base them on the transthoracic echo recommendation that ask us to measure the VHA in mid-systole and from inner edge to inner edge, while when we have to measure the other diameters of the aortic root, we should do this in diastole and from leading edge to leading edge. And indeed, there can be some important difference by 2 millimeters by measuring from inner edge to inner edge or from leading edge to leading edge, and even 2 more millimeters difference by measuring from outer edge to outer edge. So it poses some differences in analysis. And why should we, as echocardiographer by transthoracic, measure it by leading edge to leading edge? It's just because otherwise we underestimate the true diameter of the ascending aorta and of the aortic root by measuring inner edge to inner edge. But this is causing some confusion, and in the operating room we are not using transthoracic echo, but we are using transesophageal echo, and even more and more 3D transesophageal echocardiography. So there is some controversy now appearing in the literature and asking for having one way of measuring the aortic root, and because all 3D echo has about the same definition, the spatial resolution as MRI and scan, maybe we should use inner edge to inner edge measurements, but this is still a controversial topic for the moment. Another problem when measuring the ascending aorta and the aortic root is the fact that we should be well aligned with the longitudinal measurement of the ascending aorta, with the longitudinal way of the ascending aorta, and quite sometimes we have such curves of offline, and this measurement will not be true. So one way of having accurate measurements is to use multiplane reconstruction, because with not only the beautiful 3D images, but with the MPR, we are now able to align all the 3 planes and to be sure that we are measuring correct and so more accurate measurements, because we know exactly where we are. Type 2 means that we are facing a cusp prolapse, and there are some characteristics of a cusp prolapse is that you have an eccentric jet in the opposite direction of the prolapsing cusp, and you have a fibrous band that can here clearly be seen, and meaning that there is a prolapse of the right coronary cusp. You can see the band here at the level of the right coronary cusp. So we also have to do some measurements, and the 2 important measurements is to measure the cusp coaptation length and the effective height, which is from the uppermost portion of the coaptation up to the plane of the annulus. And to do these measurements, we also will have to use 3D echo. Why that? Because with 2D, we only analyze one coaptation, which is the coaptation between, we know that the anterior cusp is the right one, but depending on how we turn the probe, the posterior cusp can be either the left or the non-coronary cusp. Of course, X-plane can be useful, and sometimes we are well aligned in order to be sure that we measure the coaptation between here, the non-coronary cusp, and the right coronary cusp, and we are able to measure a coaptation here. Sometimes we are also able, by turning the probe, to have an idea of the coaptation between the left and the right coronary cusp. But look here, we are not clearly perpendicular to this coaptation, so our measurements there are not very accurate. So that's why we also need to use MPR, because only MPR offers a good perpendicularity to the coaptation, and here we are sure that we are measuring a true value of coaptation between the non and the right coronary cusps, and here we can look at the coaptation between the left and the right coronary cusp. And look here, there is the fibrous band, and here we clearly see that the posterior cusp, which is the left one, is prolabing. So it discloses a prolapse of the left coronary cusp. So clearly, MPR is very useful. And moreover, MPR is the only way we have if we want to measure the coaptation between the non and the left coronary cusp, which we cannot do with 2D echo. And thanks to this, it is possible to measure not only the coaptation length, but the Ottawa group has shown that it's possible to measure the coaptation surface area, and they have very recently shown that it's correlated, inversely correlated with severity of aortic insufficiency. Other measurement is the measurement of the effective height, and this also should be performed using MPR in order to have accurate value, the most close to the true value. Other measurements are now possible. This geometric height can be measured because we have now the possibility to have some curvilinear measurements, which was not possible earlier on, and we had to add all these small measurements. Now we are able to measure just a curve length of one cusp. And we now have appearing some software. I'm sorry, I don't have this one in our hospital, but it's coming on the market, and we have software that automatically perform all these measurements, and maybe this could be very useful. Type 3, if we want to speak about accuracy in type 3, well, first, these valves are less repairable. We should not, they have not a long-lasting result after repair, so less and less we repair this kind of valves. Maybe one new thing coming now is the possibility to have a quantification of aortic valve calcification. Maybe this could be useful in the future in order to help in deciding if a valve is repairable or not. The bicuspid valve is also a valve that needs a 3D analysis. Look at this valve. So it's a bicuspid valve with a raphe. There is aortic insufficiency. And if we want to just use the MPR or going from the short axis to the long axis view, we don't see any coaptation. But in fact, we are not perpendicular to the coaptation. We are going from one commissure to the mid of the sinus of the right coronary sinus. So we are not measuring a coaptation. And in such a case, when we have quite a vertical coaptation in bicuspid valve, we should also use MPR in order to be well aligned, well perpendicular to the bicuspid valve coaptation. Of course, 3D can help us to look at the aortic insufficiency from the aortic side or from the LVOT side, and sometimes it helps us also to look at the direction of the eye jet. It also helps us to look at this valve from the aortic side and from the LVOT side in order to better analyze the valve. But maybe the MPR is most important in analyzing this valve. And another important thing that we now do systematically intraoperatively is to measure the angle between the commissure for analysis of the bicuspid valve, going from the center of the aortic root and going towards the two commissure, because we know now that there is a whole continuum of bicuspid aortic valves, going from a true type 0 valve with an orientation of 180 degrees towards pseudo tricuspid valves with a small raphe, but with three sort of commissures at an angle of 120. So there is a continuum going from this to this and many different bicuspid valves. So looking at the angle and looking at these valves helps the surgeon to decide which kind of repair he will apply to the valve. With pseudo-tricuspid bicuspid valve, maybe he will consider commissural repair, pericardial patch, and render this valve tricuspid, while in symmetric, he will end up the surgery by rendering the valve with a 180 orientation. So it can help the surgeon to decide to keep the valve tricuspid or to render the valve tricuspid at the end of the repair or to orient the two commissure in a 180 degrees. Post-repair. Post-repair, we also have to measure coaptation length and effective height. We do it traditionally with 2D echo. And these two parameters have been shown to be the two most important parameters. Here it's a study of our group about the coaptation length, and here the Schaeffer's group about the importance of achieving a good effective height more than 9 millimeters in order to have a long-lasting result. So these measurements should also be performed with MPR, like we see here. With MPR, we are able now to measure the coaptation between the left and the non-coronary cusp. Because otherwise, look here, if we measure here going from short axis to long axis view, with the X-plane, we are at the level of the coaptation. Okay, we can measure a coaptation, but we are a little bit offline if we want to measure the sinuses. While here, it's a good way of measuring the diameters of the sinuses post-repair, but we are clearly not at the level of the coaptation. Sometimes it's hard to have beautiful images post-operatively. Here we have a small aortic insufficiency. Should we pay attention to it? Is it a problem? Then we have to find other planes, and here in the transgastric approach, we can confirm that indeed there is a very small, a very mild aortic insufficiency, and sometimes in this view, we are also able to do the measurement of aortic, of coaptation length and effective height. And in any case, if there is an aortic insufficiency that we are concerned about, we should measure the vena contracta, and again, 3D echo helps us to have more accurate measurements. And moreover, we should now measure the vena contracta area from the aortic perspective in order to be correctly, to measure the magnitude of this residual aortic insufficiency. And of course, we have to place all these together with other elements in order to decide if the aortic AI, the AI is important or not, necessitating going back on pump or not. So in conclusion, I would say that accuracy means 3D, but not only real-time 3D that gives us beautiful images, but also MPR. And this allows for a better analysis of the valve, more accurate measurements, and clearly we are now able to better guide the surgeon in his aortic valve repair. Thank you for your attention.
Thank you, Michel. As always, very nice explanation of the mechanism of aortic insufficiency, also evaluation for forced repair. You have shown very well that you can check the coaptation among all three types of valve, left, right, and non-coronary. So you can go at all levels. But in case you don't have any aortic regurgitation at the end of the operation, all this, even though you don't find the perfect lower coaptation in one couple of leaflet as compared to the other one, how does influence the next step? I mean, do this information help the surgeon to do something, or not in the post-repair? Just the measurement of the different coaptation between two different leaflets.
Yes, sometimes when we had some cases where, because the coaptation length was not high, not long enough, we went back on pump. Sometimes we have a billowing of the valve without any aortic insufficiency, and we see that the effective height is too low, then we go back on pump in order to heighten this coaptation by adding a small plication at the free margin, so even if there is no AI.
So billowing per se is an indication to increase the level of coaptation more?
I would not say that, because it's in bicuspid valve, quite often you will observe a billowing, yes, even after a successful repair. And more often for bicuspid aortic valve repair, we will accept this. And of course, yeah, now I think that Laurent will have the numbers to show you, but now we can make sure that even by leaving this billowing, and we have a very good repair that can last over time.
This is typical for bicuspid, actually, yes, because they look always more lower as compared to the tricuspid.
Exactly. I would say that maybe for tricuspid, you should try to achieve a good effective height of all three cusps.
But this is important, because even in the complete absence of regurgitation post-op.
Yes.
So that's why it's important a proper, a complete evaluation of the valve. It's not enough to just look at the valve that is not leaking.
Exactly.
I mean, just try to convey a message for everybody. Okay, thank you. Any question from the floor? Yeah, we need the lights to pick up. Yes. So Schaeffers.
Maybe just a confirmation of what you said, because there is one thing that I think cannot be overestimated. This multiplanar reconstruction is essential. Yes, it takes time to find your work, to work your way into 3D assessment, and these spatial images, these 3D images are nice to look at, but the true importance of 3D and this is so vital for adequate repair is multiplanar reconstruction. It takes some time. We as surgeons have to learn to be patient. I don't know what patience is. I have a big problem with it, as you know. But this is essential. This will help for the individual operation. This will also help us, if we do it systematically, to actually systematically improve our techniques. Michel, I assume you agree?
I totally agree with you. Yes, I totally agree. Not only the beautiful 3D images, but MPR is very important. It takes time, yes. Post-operatively, we also have to look at the patient, not only to the echo, but it's something that can help the surgeon both before and after repair.
Thank you, Michel. Thank you very much. Okay. Yes, please, quick question, because we are on a streaming, so we have to keep with the time.
Sorry about this sort of delayed questioning, I would say. Marek Josiński, Poland. What do you think about CT, then, in pre-op assessment? Is it useful?
I don't have any experience with CT in pre-op. I'm an anesthesiologist, and no, I only have experience with intraoperative echo. I'm sorry, I cannot. I'm not a cardiologist. I cannot tell you. I'm sorry.
CTs maybe. Okay. Okay, we go to the next speaker, Dr. Budwani. He will now go through the steps to repair an aortic valve, step-by-step approach.
Thank you. I'd like to start by thanking the association for the opportunity to present today. I was asked to talk about the standard surgical steps for repairing of an aortic valve. However, it's important to acknowledge first that any particular aortic valve repair would require tailoring of the appropriate techniques for that particular patient and that particular valve. I have no conflicts of interest to declare. However, with that in mind, we can think about the standard approach that one might take to all aortic valves. And I'd like to thank Michel because he's made my job a lot easier by helping us understand the echocardiographic assessment of the aortic valve. Needless to say, echocardiographic assessment is very, very important. It tells us a lot about the anatomy as well as the function of the valve. It sees the valve in a normal physiologic state, which we're not able to see surgically, and it allows us to visualize the AI jet, which we're not able to do surgically. However, it is still a two-dimensional tool, and I think this was emphasized in the discussion, where we have 3D images, but the most valuable elements are deconstruction of those 3D images to get the 2D relationships that we're looking for. It still is limited by its resolution and image quality, and definitely requires translation and a conversation between the echocardiographer on one hand and the surgeon on the other. Michel already spoke a lot about the hallmarks of cusp pathology, in particular cusp prolapse. This is a key element that all surgeons involved in aortic valve repair need to understand and recognize to the same degree of proficiency as their echocardiography colleagues. There are some standard measurements that we would expect to have at the time of aortic valve repair, and Michel alluded to these as well, so I won't spend a lot of time on these. However, I will move now to surgical assessment of the aortic valve. In contrast to echocardiography, surgical assessment is 3D. It allows you to visualize all the different relationships between the sinuses, the root, and the leaflets. It's a much more textured assessment. It allows you to assess things like cusp quality, cusp mobility, the relationship of the various elements. It allows you to see things that sometimes are not apparent on echo, like fenestrations in the cusp leaflets. And it is primarily then the basis for the type of repair strategy that's chosen. However, it is limited by the fact that we're looking at unpressurized geometry. We're looking only at anatomy and not at function of the aortic valve, and we only have the outflow view available to us for the aortic valve. Surgical assessment requires aortotomy and exposure, and the aortotomy or the aortic transection is performed typically 1 centimeter above the sinotubular junction. This is a transverse aortotomy. We place commissural retraction sutures at each commissure and then cephalad retraction of the distal aorta. With upward or radial or axial tension on our commissural sutures, we're able to mimic a distended aortic root and assess the valve leaflets. When we're assessing the valve, we're looking at aortic root and annulus, tissue quality, aortic root size, and size of the ventricular aortic junction. And we're looking at the aortic valve leaflets, focusing on tissue quality again, presence of calcification, fenestrations, mobility of the leaflet, and geometric height. We're also looking for clues to cusp prolapse. And in this area, the effective height caliber developed by Dr. Schaefer's can be a really useful tool in addition to visual assessment. At the end of echocardiographic assessment and surgical assessment, what we want to arrive at is an understanding of why this valve is leaking. And this is where a framework like this one can be useful to determine whether the primary problem is an annular problem at the sinotubular junction, at the VHA level, or at the aortic root level, whether this is a cusp prolapse issue or cusp restriction issue. And knowing the mechanism or mechanisms involved will allow you to then choose the techniques that might be appropriate for that particular valve. Once the assessment is complete, the next important step typically involves preparation for the annuloplasty or the root portion of the procedure. It's important to note that almost all aortic valve repair operations, perhaps with the exception of pediatric and congenital operations, require some form of annuloplasty procedure. And the biggest question one faces surgically is whether the root should be replaced. With our experience in the aortic valve repair community to date, certainly aortic root diameter greater than 4.5 centimeters and poor tissue quality are important indications to proceed with root replacement. Some other softer or relative indications would be presence of significant VHA dilatation or the presence of connective tissue disorder. However, there may be factors that also sway you towards preservation of the root. Coronary artery anomalies are one example, as well as patient factors like left ventricular dysfunction, advanced age, or presence of comorbidities may push you towards a root-preserving valve repair. If you are replacing the aortic root, really there are two strategies that are emerging as the predominant strategies: valve sparing with a reimplantation technique, or valve sparing with a remodeling technique with some form of adjunctive annuloplasty of the ventricular aortic junction. In the non-root replacement, annular interventions may include a subcommissural annuloplasty, an external ring at the ventricular aortic junction level, or in addition at the sinotubular junction level, internal annuloplasty systems, or suture-based annuloplasty. A short video on the left shows the dissection and access of the ventricular aortic junction in a case where aortic root replacement is being performed. And this is an important technique that all surgeons would need to have in their armamentarium as they perform aortic valve repair procedures. This is a case of a Marfan syndrome with aortic root dilatation, so the root will be replaced in this case. We start with external dissection along the non-coronary cusp, down to the level of the ventricular aortic junction. And this is one region of the valve where invariably it's easy to get down to the base of the leaflet insertion. You can always confirm that by looking from the inside, and that particular sinus can then be resected. Following this, we harvest the coronary buttons, and we start with harvest of the right coronary button, which allows us access to the ventricular aortic junction at the level of the right coronary cusp. Here is where we reach our anatomic limitation that is posed by the membranous septum that comes up. and limits our ability to go all the way down to the ventricular aortic junction plane in a horizontal fashion. Once this portion is complete, we then harvest the left coronary button, and harvesting of the left coronary button allows us then to complete our dissection below the left sinus. And finally, following that, we will see that we complete our dissection down to the level of the ventricular aortic junction between the right and left commissures. In contrast, I'll also show you a short video clip of a scenario where you don't have root replacement. And in this case, again, the non-side of the aortic root is easily accessible. However, the coronary arteries get in the way of our ability to access the ventricular aortic junction. So in this case, after the non-right region is dissected to the extent possible, we move to the left-right region. And we dissect down all the way to the ventricular aortic junction. It's important here to divide the connective tissue connection between the aorta and pulmonary artery to get to the muscular level, and then a tunnel is created between, or behind rather, each of the coronary ostia. This allows us to circumferentially access the ventricular aortic junction. To perform the VHA annuloplasty, one approach is a reimplantation technique, and this is what's shown in the screen on the left, where you pleated 2 Ethibond sutures are placed circumferentially at the level of the ventricular aortic junction. And once your graft is prepared and tailored to accommodate the external limitation at the right non-commissure, the sutures are passed through the graft is parachuted down, and this then becomes the ventricular aortic junction annuloplasty. In a scenario where you don't have a root replacement, same sort of suture configuration can be placed, starting with the non-left commissure, leaving a small space for the coronary arteries, but continuing the same circumferential annuloplasty sutures. And once these have been placed circumferentially, a ring or a band of Dacron, as is used in this case, can be placed under the level of the coronary arteries. The sutures are again then passed through, with the final suture closing off the opening in the Dacron band. And finally, this becomes your ventricular aortic junction annuloplasty. It's important to emphasize this technique above all the many techniques because accessing of the ventricular aortic junction is critical to aortic valve repair procedure. I'll move on to give you a glimpse of cusp prolapse repair, as that is the most common pathology encountered. Cusp prolapse accounts for over 1/3 of all aortic valve pathologies and over 50% of the cusp pathologies encountered. It is important to note that prolapse may be pre-existing. It may be unmasked because of the aortic root and annular operation performed, or it may be induced by technical issues at the time of aortic valve repair procedure. Free margin plication is the most common technique, and I'll give you a short glimpse of this. Important for the free margin plication technique is the obtaining of a reference cusp. This is done in this case with a right coronary cusp prolapse. The other 2 cusps are used as a reference, and a suture is passed through the nodule of Aurantius of both of those cusps. The prolapsing cusp can then be aligned with the reference cusps, and a suture is passed from the aortic side to the ventricular side. The other opposing edge of that same prolapsing cusp is now aligned with our reference cusp, and the same suture is passed from the ventricular side to the aortic side. And this gives you an excellent estimate of the amount of excess free margin that needs to be plicated to render this valve competent. This plication can then be extended to the body of the cusp to complete the plication procedure. In a bicuspid valve setting, in this case, a non-conjoint cusp itself is prolapsing, so the first step is to plicate the non-conjoint cusp and make it an appropriately measured reference cusp. And then this non-conjoint cusp becomes our reference against which we can perform a free margin plication of the conjoint cusp. There are adjunctive techniques for cusp repair. I will not go into all of them, but shaving and trimming of the cusp is something that can be useful in patients who've had chronic regurgitation, who have thickening of the free margin. This can be performed by placing a 6-O-proline suture along the thickened portion, typically on the ventricular side, and sharply excising the excess cusp. This renders the cusp much more pliable and amenable to the interventions like free margin plication. Similarly, in a bicuspid aortic valve, shaving of the raphe, which can be sometimes quite restrictive and limit leaflet motion, can be a very valuable technique to try and render a thickened, less mobile valve repairable. And most of the time, this can be done without infringing on the actual cusp body. I'll talk briefly about post-repair assessment. Post-repair assessment is largely an anatomic assessment. It's not a physiologic assessment. We first look at anatomy by getting the cusps to coapt with axial tension on our commissural sutures to distend or try to mimic a distended aortic root. Following this, the root can be pressurized with some saline and give you an impression of what a pressurized aortic leaflet configuration would look like. Once the coronary buttons have been implanted, another technique that's useful is giving cardioplegia down the graft in cases where you do have a graft. And this not only pressurizes the root, but sometimes also gives us the opportunity to have a limited echographic view of the aortic valve. And once the cardioplegia has been administered, we have an excellent pressurized anatomic view of the valve leaflets. Here, again, if in addition to visual assessment, the effective height caliper can be quite useful in ensuring symmetry of all three cusps and ensuring a minimum height of the leaflets. And lastly, post-repair echo assessment is what Michelle already spoke about. We want to make sure that we avoid leaving behind residual AI, particularly that which is eccentric. We want to ensure that there's a minimum coaptation length of greater than 5 millimeters, an effective height of greater than 8 or 9 millimeters, and not leaving behind a large annular size. In summary, aortic valve repair requires a tailored approach to each patient and valve. However, a standardized approach with key steps can be used to systematize all aortic valve repair procedures. And my last point to drive home would be that surgeons need to have a thorough understanding of the echocardiographic and surgical valve assessment to be successful at aortic valve repair. Thank you very much.
Well, thank you very much. There's been a very clear explanation of the steps of aortic valve repair, and the images were quite impressive as well. We're just a little bit behind schedule. Unless someone has a question on technical issues of aortic valve repair.
Muri, perhaps you can just outline briefly when you decide to go for a root replacement or just for annuloplasty. What is the size or the tissue quality that makes you to go one direction or the other?
Right. The way I would summarize that question, because it's a very common question, is that if you have aortic root 4.5 centimeters or greater, I think the answer is simple. I think our guidelines would suggest that we would want to be aggressive and replace those. If the aortic root is less than 4 centimeters, we rarely get into a situation where we replace the aortic root. So the gray zone really for the surgeon is where the aortic root is between 4 and 4.5. And here there are other softer factors that I would use in my practice. One is the aortic tissue quality, as you suggested, the presence or absence of connective tissue disorders. Any of those would make us be more aggressive for root replacement. And then lastly, again, a softer reason would be a very dilated VHA. Because sometimes it's difficult to access and have sufficient VHA annuloplasty without a root replacement procedure. If there is excessive cusp restriction in a bicuspid aortic valve, again, a root replacement procedure gives you more ability to tailor that valve, and I'm sure we'll hear more about that in subsequent talks as well. But those are the three criteria I would use.
Yeah, thank you. Makes perfectly sense. Another quick question?
Oh, yeah, all right. Yeah, I'm heard, right. I would like you to elaborate a little bit more on external annuloplasty. I mean, because actually there is a one weak side of this technique you presented, actually, We all appreciate the idea behind of the external annuloplasty, especially this is how the reimplantation technique and is fundamental part of the reimplantation. However, during reimplantation we are just based on some kind of measurements. For example, we are just measuring height of the commissura in terms of choosing the proper prosthesis size for the reimplantation, meaning that we've got the certain size for the annulus stabilization. Now, just having a strip of Dacron, whatever, taken, I mean, you know, how you, at the end of the procedure, make sure that you end up with the proper or predicted size of the annulus?
Thank you. Great question. I think there are two questions here in the comment that you make. One is, what is the desired final VHA diameter that you want? And we need to know what it is. If we start off with 29 or 30 or 28, where do we want to end up? Do we want to end up at 23 or 24, et cetera? And the second is, how do we get there? What techniques would we use? So my approach to this, again, is that you can use the same sizing method that you use for a valve-sparing reimplantation approach. You can still measure the left non-commissural height and use that as the size of the, for example, Dacron band that you would use. So it, in fact, has the same effect as a valve-sparing root replacement has, because it's implanted in exactly the same position. The question is, how do you achieve that size? And again, I would argue that if you do the same circumferential annuloplasty sutures as a root reimplantation procedure, and now you restrict by the same size band, that it helps you achieve the desired annuloplasty. So to sum it up, you know, we've learned that valve-sparing root replacement reimplantation provides us with a very stable and durable result in terms of annuloplasty. So to the extent possible, I try to use the same guides as I would in a reimplantation procedure for choice of the prosthetic.
Okay, thank you very much. So, Jun, bicuspid aortic valves have some peculiarities and some differences with regards to tricuspid. So, Jan Wojciech from Radek Kralovi in Czech Republic hopefully will tell us about the characteristics of bicuspid aortic valve repair. Thanks.
Thank you. Good afternoon, everyone. Ruggero, Rafa, thank you for the invitation. As you know, leaking bicuspid valve has a good potential for aortic valve repair. Why? Because there is low incidence of valve-related complications, and we do know it. And there is also better quality of life, as we, for example, proved in this nice paper. So therefore, it should be a procedure of choice for young and middle-aged patients. However, there are some concerns regarding the durability and risk for redo. And this risk is not zero, as you can see from this nice meta-analysis published in Annals in 2015, and where all major players were included. This risk is in between 10 to 13% during 10 years. So what are the standard surgical steps to repair a bicuspid aortic valve to ensure good and durable results? This is a beautiful classification of aortic insufficiency, repair-oriented classification, and as you can see, there are three types of aortic insufficiency: type 1, type 2, and type 3. And as you know, for bicuspid aortic valve, there are always some prolapse of the leaflet, so there is type 2, and almost constantly there is some degree of annular dilatation, and in most of the patients some degree of aortic dilatations at a different level. So we have basically a combination of type 2 and type 1, so we are lucky because we have strong support from current European guidelines in class 1, as you can see, for non-calcified tricuspid or bicuspid aortic valve who had either type 1 or either type 2 mechanism of aortic insufficiency. And there is also strong recommendation for both types of aortic valve sparing root replacement, either for reimplantation, but also for root remodeling, but also along with a precise extra-aortic or some kind of annuloplasty. So Let's start with type 2, correction of the cusp prolapse. As I said, in case of bicuspid aortic valve, there is always some kind of prolapse of the fused leaflet, which must be corrected. As you can see on this picture, this is a bicuspid aortic valve. Sinus of Valsalva were already resected, and fused leaflet, which is always longer, was plicated by this central plication stitches. So basically we have simple situation in case of bicuspid aortic valve, because both free edges of the leaflets must be of equal, identical size. We also need again, this is another example from the surgery. This is rare phenotype of bicuspid aortic valve with the fusion of the right and none. And you can see this is the left coronary cusps, and there are actually two separate ostia of the LAD and circumflex. And this is another example of bicuspid aortic valve where we have to resect it, heavily calcified raphe. Also, we need an optimal cusp configuration in terms of the effective height. And from the echo studies in healthy patients, we know that this distance, this effective height, should be at least 9 millimeters. Whenever it's less, it's basically prolapse, which must be corrected. Luckily, we have this dedicated aortic caliper, which could be used for intraoperative measurement of the effective height. As you can see on this picture, this is bicuspid aortic valve after root remodeling, and as you can see, this free leaflet is touching the bar, so there is a sufficient effective height. Well, we always have to start with valve analysis, so we put these traction sutures, as you have seen already, to mimic a pressurized aortic root in this case. Again, bicuspid aortic valve, the root was already resected, and this is the fused and non-fused leaflet, and this must be actually used as a reference leaflet, so one has to be sure that there is a sufficient effective height. Once you have it, you can use it as a reference leaflet for adjustment of the free edge of the fused leaflet, which is always longer, as you can see here. So basically now you have this excess of the free edge, which must be plicated. As you can see here, with 5.0, you can easily plicate the fused cusp and to obtain optimal coaptation and configuration. So now both free edges of the leaflets are equal, and all you have to do is to put another stitch and then another stitch to close the gap. And that's it. So, as you know, there are three phenotypes of aortic root and ascending aorta. In this case, where aorta is normal, no dilation, we simply proceed with isolated aortic valve repair. If the root is involved, you actually have to proceed either with David procedure or Jakub procedure. Those procedures, according to me, I mean, they are equals. And it's also the question what you believe in, and I believe that Jakub procedure is a nice procedure, so this is the procedure of choice at my institution, but always along with this precise extra aortic annuloplasty using expandable coronary ring. So let me show you how we do this. Aortic remodeling in case of bicuspid aortic valve. So we always start with deep dissection of aortic root, so ascending aorta is transected just a few millimeters above STJ, and we start with dissection at the level of non-coronary sinus, when we have to dissect the root from the roof of the left atrium, which is actually the easiest part of the dissection. Then I continue at the level of the right coronary sinus, and once the coronary bottom is excised and put under tension, you can continue with the dissection here, which is not so easy because there are, let's say, anatomical limitation. Because here, at this right coronary sinus, ventricular aortic junction is always above a few millimeters above basal ring, so it's difficult to reach the plane of the annulus. But anyway, you have to be as aggressive as possible and then to continue with excision of the left coronary bottom and finish the dissection at this level, at the level of the left coronary sinus, where again it's quite easy to reach the plane of the annulus. Then you have to resect dilated tissue of aortic sinuses, and dissection is finished. Then we have to put the sutures for the ring, which are basically the same technique as you have seen already, like for the David procedure. So for this ring, we use 6 stitches, which are placed as U stitches from the inside out in a clockwise fashion and in a single horizontal way. So these stitches are then used for the ring fixation. So 3 of them are put just at the belly of each cusps, and 3 of them are placed at the level of the base of subcommissural triangle. Then we continue with root remodeling. For this we use this Valsalva prosthesis, and this is important for in case of bicuspid aortic valve. We created just two tongues, 2 neosinuses. Why? Because we know that in case of bicuspid aortic valve, the optimal configuration is like in pure bicuspid aortic valve, there the commissures facing each other at 180 degrees. So that's why we create these 2 identical tongues, identical neosinuses. Then this prosthesis is sutured to aortic annulus, to the leaflet attachment using this fine suture, and it must be very delicate and hemostatic suture. Here at the level of the fused cusps, you have a chance to plicate the sinus a bit, so you should make a bigger step on aortic tissue and make a small bite on the prosthesis, and in this way you can basically to shrink the sinuses and to bring the commissures at 180 degrees orientation. So this is the way how we do remodeling, and then we have to put the ring. We use a coronary ring, and so those previously placed sutures are put through the ring or currently around, which is basically better. And once they are put through the ring is descending to the proper position and fixed in a proper position by tying those sutures. Then final tuning. This is extremely important. Why? Because once you do either remodeling or reimplantation, you always change the size of STJ, so you can easily induce a prolapse, and you have to be sure that this is not the case. Then you have to put again these traction sutures and measure again the effective height, and if there is a prolapse, you have to make another central plication stitches, like was in this patient. There was a heavily calcified raphe which was resected, and you can see the final result. Very nice coaptation. Well, this is for root remodeling, and I would like to briefly mention also the case what we do in isolated aortic valve repair. First, you have to deal with dilated aortic annulus. There are a few options. First is subcommissural annuloplasty, so-called Cabral technique. But even so, this technique is very easy and low cost. It doesn't provide a circumferential stabilization of the aortic annulus, and there is a tendency for redilatation, and there is a risk of redo, and that's why it should be abandoned and leave it only for bailout options. But there are 2 good techniques how we can stabilize the annulus, and it will be mentioned during the second talk, so I will just briefly mention this annular stitch, which was proposed by Professor Schäfers. And the other option is this so-called open ring. which is basically a strip of dacron which is placed around the annulus at the level of the basal ring, using exactly the same technique like for the placement of coronary ring. So you put these six sutures and you have to dissect the root, but without the attaching of coronary buttons, and this is the way how we can stabilize the aortic annulus. So which technique is actually better? I would say subcommissural plication, as I said, is abounded and should be used only as a bailout option, and either annular stitch or open ring are very feasible. They are very effective, and it's nice to have them both in armatorium. Why? Because sometimes you have to face this situation. I made this drawing by myself, and as you can see, this is the right coronary sinus, this is the origin of right coronary artery, this is the basal ring, and as you can see, at this level, aortoventricular junction is always above, a few millimeters above the basal ring. And in this case, it's difficult to go from the outside, and in this scenario, I'd rather put the stitch from the inside, and then I'm sure that I do the annuloplasty in a proper position. So let me summarize. Repair of the leaking bicuspid aortic valve is possible in many patients with or without concomitant aortic dilation, and there is a low incidence of valve-related complications. There are a few critical steps which must be addressed in order to achieve a good result, like correction of the prolapse and normalization of the geometry of aortic root at different levels, and also you have to address the commissural orientations. Once you do it, this is an excellent procedure for young and middle-aged patients, and there is a strong recommendation for this procedure in current European guidelines. Thank you for your attention.
Jan, could you, since now you show this remodeling plus annuloplasty is becoming very similar, not to the reimplantation, the difference are slowly disappearing. How would you explain your preference for this procedure as compared to the other one? What are the key factors in your experience or in your practice?
Well, basically, first I said that those procedures, according to me, are almost equal, and you know, even the results are very similar, and they are not so influenced by this or that technique, but mostly by patient selections and how you deal with the leaflets itself. But why I do believe in this procedure? Because first, it's probably less time consuming comparing the David procedure. It's too easy to perform. Then there are some, at least theoretical advantages of root remodeling over implantation in terms of leaflet movements and opening characteristic of the leaflets. And then also you can do annuloplasty more precisely comparing the David procedure, because you can select the proper size of the ring. And there is another, at least theoretical advantages of this expandable ring, because this expandable ring actually enable the movement of aortic root at the level of subcommissural triangle. And actually my group proved that this expandability is sustained in vivo.
And do you see this expansibility in vivo for how long?
Well, we did a CT study, 2 years follow-up. That's all we have.
Mm-hmm. Okay, thank you. Dr. Dyszyński, we're waiting for your question.
We've just been discussing and things, you know, you just presented very nicely, and actually something in common with the previous presentation. Yes. Again, the issue of external annuloplasty, and actually the question we just elaborated on, I am just passing to you, is how are you choosing the size of the of this ring, external ring, Lanzac ring, whatever we call it, well, in both situations, when it is open ring And when it is...
The sizing is the same. The sizing is the same, so and basically one needs to realize then in between the ring and the inner diameter of actually of the aorta, of the annulus, is aortic tissue. So it's always diameter of the prosthesis of diameter of the ring -5. So when you have, let's say, the ring, which is 28 millimeters, you will end up with the diameter of the annulus like 23, 22. And sizing, well, we rely on one single measurement of the aortic annulus. So let's say if you have aortic annulus 28, 29, I choose a Valsalva graft of 28, and for the ring, I always downsize by one size, so I would put 27. Then I have
sorry, we have to. Sorry. We are running behind the schedule. I'm okay. Really sorry. We have to carry on. So if we can have the next speaker is Dr. Taggart from Agia in Japan. So he will be talking to us about their experience with virtual reality to reconstruct aortic valve leaflets. So please.
Thank you. So my presentation is a little bit different from aortic valve repair, but our aortic valve reconstruction with 3 same-size autologous pericardium leaflets have been performed for patients with narrow aortic root or contraindication for valve prosthesis. Since this procedure required precise information of the aortic root, including configuration of valvular sinus, we assessed physiologic and anatomical condition of the aortic root by virtual reality VR images in order to accomplish this technique with reproducible fashion. The purpose of the study is to establish the reproducibility of our procedure and analysis of physioanatomical condition of aortic root using VR image evaluation, and also to clarify early stage outcome of our procedure. So we have been performed since 2009, a so-called Professor Son's Carver procedure, and after 2016, we installed our VR analysis. So we did 17 cases for limited cases, limited indication. So basic surgical technique is same size 3 leaflet. It's designed based on the STJ diameter, and the leaflet are sutured on the cusp suture line in 3:2 ratio from nadir to commissure height, and 1:1 in commissure part. So this is a short video for procedure. After sizing of STJ, we put in the marking of the nadir of the leaflet attachment. And also we decided 5 millimeter coaptation height. So also we mark. And then our leaflet is sutured from the bottom to the commissure height to 3:2, and for commissure zone, just suture 1:1. So pericardium treated by glottal height for 6 minutes. So after completion, we put in the coaptation stitch between each leaflet to prevent from minor leakage and occlusion of coronary arteries. So talking about VR analysis, enrolled patient underwent enhanced ECG-triggered cardiac CT in order to make STL5. VR image of aortic root was created using workstation called Bizarrius 3D by the data from CT. This is an image of virtual reality. So you can see the aortic root. Actually, the operator wears 3D glasses, and we measure diameter and aortic annulus position, and also each level of valvular nadir, like that. So with VR image, we did some adjustment procedure for annulus, especially non-coronary nadir of Valsalva was deviated toward LV in some severe AR patient. This portion is dilated. Portion is a so-called fibrous portion of the aortic annulus. And also for limited patient, new 3 commissures and adjustment of the aortic root should be necessary in the patient, like type 0 or type 1 bicuspid aortic valves. So I bring example for the application of Valsalva. This patient had a severe AR and non-coronary cusp nadir is deviated toward the left ventricle, like that. These kind of findings is not so easy to identify even in the operating field. So according to the information, we simply plicated Valsalva with 4-prolene to adjust the nadir level for our leaflet procedure. After completion of nadir application, just forward to the leaflet attachment. So in this case, Valsalva sinus of non-coronary cusp was adjusted as preoperatively designed, like that. So this is another example. It's bicuspid cases. We designed the 3 leaflet, same size leaflet reconstruction like that, and transcription model was made by Bizarus 3D workstation. And actually, we copied this one, or 3D copied, and decided the precise position of the leaflet attachment, and then proceed the procedure. So this is the result. It's a very good opening and no deflection at all, and no AR. So we did, as I told you, we did about 50 cases. We had 2 cases converted to the AVR due to AR more than mild. But after we installed VR image analysis, we have no conversion to AVR. So we did additional procedure in 8 patients for crescent form Valsalva application, and we applied a 3D model for suture line indicator in 2 bicuspid cases. So of course, the follow-up is very short, but so far we had no AR and no redo case and no IE. And previous reference cases also not so bad, but mild AR occurred in 10 cases in 47 cases. So in conclusion, our method with adjustment techniques could bring anatomical and physiological correction with excellent hemodynamic outcome without major deflection of coaptation lines. And the VR image analysis revealed precise information of aortic annulus. Even tricuspid AR patient, the nadir of non-coronary Valsalva often deviated towards left ventricle. Information by VR analysis are not easy to clarify by ultrasound examination, and also even in intraoperative findings. So further strict follow-up is indispensable to evaluate this procedure. It's very important. And also alternative materials or other treatments of autologous pericardium should always be considered for further development of this kind of procedure. For additional analysis, we would like to progress blood flow dynamics in aortic root in VR analysis, and also shear stress of leaflet in various kinds of Valsalva. This kind of VR image analysis is probably very important, and if we apply the ultrasound examination, it should be very helpful for our surgery. Thank you for your attention.
Well, thank you very much. It's quite impressive technique. So in what patients would you not be able to do this? What are the main contraindications for, or what type of patients?
Yeah, this series is very limited patient, I told you. But if a patient had a very dilated STJ greater than 30 millimeter, it is not good for this kind of operation. And also, we have no good vessel on the STJ ring, artificial ring. So AAE patient is the contraindication of this kind of patient.
Right.
You have any question? No? So thank you very much. I think you can break 10 minutes and then we reconvene is, a quarter to four for the next presentation.
Well, welcome back to the second part of this session on practical approach to aortic valve repair. May I remind you that this session is being streamed live on social media, so hopefully we'll have many people out there watching the session. So the next speaker is Dr. Joseph Bavaria, coming from Philadelphia, the United States. He will give us some indications on when not to attempt to repair an aortic valve and what to do if once we've done it, it fails. Joe, thank you.
Thank you. So this is an interesting talk. Usually I'm asked, or those of us that do this a lot are asked, you know, how do we do it? Well, so this will be really about what to look forward, you know, what to look for and how the decision making is regarding when not to do a valve, so to speak. So I have no conflicts with this particular presentation. So the most important thing is that the present data that we have on when not to do a BAV repair is our general consensus, which is when there's leaflet calcification, which I think is the most important one, and is the one that we grapple with on a pretty much daily basis. How much calcification, what's too much, how much debridement is okay, or any debridement, things of that nature. Leaflet fenestration is another issue if it's too severe. The need for patch augmentation, which is actually very interesting regarding the lecture that we just had. You know, patch augmentation has not been very successful in bicuspid valve repair, so it's interesting to see some of these Ozaki techniques and where they're going to go. And there's general evidence suggesting that there could be an issue regarding decreased leaflet surface area, which is more of a relative issue, and what to do about that, which is also gets into the idea of patch augmentation, because that's the reason why you would do a patch augmentation. So I was asked to do live in box, so I'll go through a number of cases just to show what we have, okay, and some of the issues. So this is a 68-year-old male. He presents with a bicuspid valve, and this particular patient is severe AS, 67 and 42 millimeters of mercury. So you think, well, we'll just put a valve in. He has mild AI, an ascending aortic aneurysm of 5.1 centimeters. But there's this concept of pseudo-aortic stenosis, which is where the echocardiogram shows high gradients in the significance when you have a significant AI. So I go into almost every bicuspid case, unless it's really obviously very, very calcified, to think about a valve repair. So let's take a look at this one. This is the easiest one. So you can see that we have pretty severe AS when we look at this echocardiogram. We're probably not going to be able to repair something like this. But he's a pretty young guy, and he's pretty fit, and so we'll take a look and see what it shows. You can see a right-left Sievers 1 BAV in this case. And here's without any color, and you can see it's probably not going to be repairable. And we discussed this with the patient, but I'm going to take a look at it anyway. And this is our echoes, and you can see that we have a 4.1 centimeter root and an annulus of 2.83 centimeters. So here's the picture, and I hope this works. Yeah. Yep. And you can see that this is a very, very calcified aortic valve. Here we're trying to see if there's any kind of motion of this valve. This is not pseudo-aortic stenosis. This is real aortic stenosis. And so we're not going to go ahead and repair this. And we abort. And I'm taking the decision towards an aortic valve replacement. And you can see that we have a very calcified valve here. And we put a big valve in this. So the case review for this one is the calcification was simply too much, especially for a 68-year-old. This was not AS. I mean, this was AS. It was not pseudo-AS, which you can see in severe AI cases. AVR was the correct thing to do. We put in a very large 29-millimeter valve. So here's case 2. 61, presenting with a BAV, moderate AI, +2 to +3, ascending aortic aneurysm, 5.5 centimeters, with proximal arch extension. And this is an ascending phenotype BAV aortopathy. And the valve, his valve, is actually not his problem. So we're not operating on clinically for his valve. His valve was fine in the sense that he was asymptomatic from his valve. So we have a little bit of a problem here. So here's your valve, and this is a very subtle finding. if you look over here, you can see that he has a bicuspid aortic valve and he has a calcified raphe. He also has a leaflet that's not that big, the non-conjoined cusp. But you can see this thing coming in and out, this echo contrast here. Here's your +2 to +3 AI picture. This is still shots, and you can see that he has a 4.2 centimeter root and a 2.7 centimeter annulus. So we're getting in, and we're going to do a valve analysis, because I do a valve analysis on everybody, because I want to try to repair as many valves as possible. And you can see that we've got this kind of, he's a pretty young guy. It's a nice valve, but it's just it's got a big chunk of calcium right here. Here's your raphe. So the calcium's on the opposite leaflet. So I'm going to try it. I'm a little bit upset about this case, because he's not really here for his valve. His valve looks good, and I really don't want to have to replace his valve, but it ended up being a little worse than I thought. And he's 61, and he's got this big chunk of calcium here. This was very difficult, and I decided, I don't know what you all would do, but I decided that this was not going to be repairable, and we did an AVR here. This would be a nice thing for discussion, whether someone of maybe Jabrine's group would have decalcified this valve. So when we do the case review for decision, this case was extremely difficult, I mean, theoretically, because his primary reason for surgery was his 5.5 centimeter aneurysm and not his valve. He's only 61, he looks great, and these are valves we really want to save, because patient is not in your OR because of the valve and is asymptomatic. This was a difficult decision, but I just thought that the calcium was too high, so this is just too much. So this is an example of maybe what not to do. Now we have a younger gentleman. This is a 49-year-old. He presents with a BAV, severe eccentric AI. He has mild AS, 15 millimeter mean, but he's got a severe AI LV-EDD, which is big. And he's got an ascending aortic aneurysm of 5.0 with proximal arch extension. Again, is this pseudo-aortic stenosis, or is this regular aortic stenosis? So let's take a look. So here we have the echo, and you can see it's got significant AI. You'll see this echo is interesting. Here's your left-right raphe. The valve is a classic bicuspid valve. It's got a big leak right here, and you can see on the posterior leaflet, usually the normal leaflet, you can see this thing coming in here. So it looks like we might have a problem on both leaflets, which is probably, and it wasn't moving as well. So you can see this here. If you look at this leaflet, usually this leaflet here will open up very nicely, and it's restricted. It's supposed to be a beautiful leaflet, and it's not. So we have this big eccentric AI jet. So here's what we're looking at. What not to do. He's got this. Here's this conjoined leaflet over here. Here's the non-conjoined. You see this calcium. He's only 49, and this is a big calcified load right here. We'll take a look at this leaflet. You can see that the valve, here, I'll show it to you a little bit later. We'll go to the next one. So here, we're looking at this valve. You can see we have this calcification here. I suppose we could try to decalcify this. This leaflet is not too bad. It's about 5 or 6 millimeters longer and prolapsing compared to the other leaflet. And you can see we have redundancy of the conjoined leaflet. So now we're really we got a 49-year-old here. We can probably save this valve, but to do so, we would have to decalcify this because that's what we end up doing. So here's my decision in this case, and this could be, again, something that I would like to hear Laurent, is whether this would be something they would have saved. My decision on this 49-year-old was that this was not going to hold up with that big calcification, and we decided towards aortic valve replacement with a big 29 millimeter valve. So this was difficult. His primary reason for surgery was both AI and aneurysm in this case. He's only 49. This was not pseudo-AS. He did have some mild AS, which was real. The calcification, especially in the posterior leaflet, where you would like to have really a good motion of the valve, was not going to happen. So this was a very difficult decision, this 49-year-old. Okay, case 4. This is a 64-year-old with a BAV, 5.2 centimeter root aneurysm, otherwise totally healthy. He had no real AS and no real AI, so it was basically a physiologically normal valve. His EF and his LVEDD were normal. And his aortic topathy was a root phenotype and not an ascending aortic phenotype. So here's what you're looking at. Here's the preoperative echo. He's got nice leaflets. They're not very calcified. They're moving up and down. You can see that he has this root aneurysm. And you can see he's got really no AS and no AI. It's a beautiful valve. And we certainly don't want to lose this valve. We definitely want to repair this valve. So, but here's what we have when we get in the operating room. We have a big fenestration. And this is not a classic fenestration at the commissures. This is a multiple fenestration, a kind of a mild Swiss cheese valve. You can see these little fenestrations. There's one big one throughout the entire conjoined leaflet or anterior leaflet. So the question is, we got this normal valve. This is totally physiologically normal. And as you can see, I'm doing a David 5 here. Am I going to save this valve or not? And he's only 40-something. So I made the decision that we would actually do an operation, do a BAV repair on this case, and not do an AVR. And so the nuanced concepts is that about sizing. This is not a normal commissural fenestration. How would you design your operation around this? The height of the raphe was 20 millimeters, much greater than usual. Would you release this raphe, and would you abort, or would you not? And so what we decided to do was do a D5. You can see the D5 here with the Valsalva graft. And what I tried to do was I brought it in just a little bit, just enough so that we had a very nice coaptation zone, and all those fenestrations were included in the coaptation zone. So this is kind of what we did. We have a nice result with no AI. And in this particular case, we decided not to abort and proceed ahead. So case review for decision-making in this one is that despite the fenestrations, this valve was totally normal preoperatively. There was no AS, no AI. Therefore, I was willing to see how the repair worked and reclamp if necessary, and just stuck to the principles of bicuspid aortic valve repair and aortic root surgery. So this is a 29-year-old, so this is a very young patient, class 1 CHF, BAV with severe AI. And you can see this is torrential AI. This is a dramatic AI. He does not have a root aneurysm here in this case. He's just a simple, straightforward AI case. So we're in here and we see at 29, we don't see a whole lot of calcium. We've got this non-conjoined cusp, which has got a cleft in it, but there's pretty good motion of the opposite leaflet. So the non-conjoined leaflet has great motion. So we're going to do an equalization of the free margins here and take the cleft, if you want to call it that, and equalize the free margins on both sides. And that's kind of what we're doing there. And so we're completing this. Now in this particular case, so we're completing the closure to make sure that we have equalization of the free margins on both sides. Now this is, I don't have a corneal ring. Well, nobody has a corneal ring for this, but so we do a little bit different than what Jan just talked to you about. I usually do 5 sutures between the 2 coronaries on the greater curve, and then 1 suture perfectly placed in the middle, and go subcoronary as low as I possibly can with the subannular ring, just like I would do a David 5 procedure. So in this particular case, we're assessing valve competence. He's only 29 years old. I'm happy with the valve repair. It looks reasonably decent. And I'm going to just go ahead and close and look at the echo. And here's my echo. And you can see that I've got a little leak here on the commissural leak. And I've got a leak here at the coaptation zone. So I'm not totally happy in a 29-year-old. So I decide to go back on bypass in this 29-year-old and look at the valve a little closer, use the data, as you heard earlier, use the data from our echocardiographer to pinpoint exactly what the problem is, and put in an additional leaflet plication in this case. And when we came off, we had no AI at all, 0 AI. So this is how you can kind of go back and look at it. So last case is a 71-year-old. This is BAV. He's got moderately severe AI, mild to moderate AS, 5-centimeter aorta, and you can see that he has a lot of AI, a ton of AI. This is an interesting, the valve assessment. We have this large, he's 71 now, remember. He's got an excellent leaflet here, good motion. This leaflet here, though, is got a big calcified load on it in the conjoined cusp. So I debride the valve, and we're taking a look at that, and it ends up being quite a debridement. You can see this. And I don't like it because it just doesn't seem like it's going to hold up. So I decide in this particular case to do a resection, do a triangular resection of this area, like a mitral valve. And we're going to cut this part out so that we have good tissue to sew to. So we cut this whole little triangle out here, and then we're going to try to repair it. We do that. We put these stitches in. It's almost the entire length. I finished the case, and I don't really. I'm just looking at this, and I don't really like it. I would like to see what maybe Laurent would have done with this. But I decided that he's 71. I didn't think, here's a piece of calcium here. Even though we tried very hard to save this valve, I decided to abort. We decided not to do this case and put in a regular aortic valve. So in conclusion, BAV repair with AI, with or without root aneurysm, is a good operation in selective patients. I do a lot of it and endorse it. However, there are significant relative contraindications to repair where the results are simply not satisfactory. They include calcification, fenestration, and the need for patch augmentation, which is usually related to decreased leaflet surface area. Note that all cases need annular stabilization unless Joachim tells me differently in a few minutes. And remember, BioRoot and Bental outcomes are excellent options and should never be considered a failure. Thank you. Let me sit there.
Yeah, we can sit here at the end, but first maybe few questions. I'm sure there are some questions. Microphone number 6, I see Dr. Rankin, I guess.
Yes, Scott Rankin,
yes.
Nashville,
Please.
Tennessee. Joe, I really enjoyed your talk, and you may or may not remember that in the 80s, we did a series of 25 patients where we decalcified, heavily calcified valves with the CUSA. And about a third of those patients came back within 4 years with aortic insufficiency. The annuli weren't stabilized and so on. And so we abandoned that. But ever since, we've been decalcifying valves, especially bicuspids, if the surface area of the leaflet is less than 20% calcified. Those patients have done great. And, you know, we're building our series right now. We'll eventually publish this, but I can just tell you that except for the first patient there, all those patients could be decalcified with CUSA and they would do fine.
Yeah. You know, I've been doing I've been more aggressive as I've done I've done about 250 of these now. So I am getting a little bit more aggressive, although I want to tell the audience that you probably shouldn't start off doing a whole bunch of calcified bicuspid valves. So we are doing more decalcification, I must admit, and I know what your data is. Also, but on the other hand, I got burned about 6 months ago where I decalcified one, thought it was real great, and it was all nice. But about a week later, it kind of ruptured right through the base of the valve where I decalcified it, and we had to go back and fix it. So it's an interesting point, and I understand what you're saying, and I think you may be onto something.
Well, you know, we are starting to decalcify heavily calcified valves again in selected cases with ring annular stabilization. Even if the leaf is scar and retracted a little bit, they're not going to get AI. We did a marathon runner a year ago in Cincinnati, had a vertical type 1, or type 0, vertical type 0 with just calcium everywhere. And it just shelled out. Yeah. There are some of these patients where it just shells out and the leaflets look nice, and the guy's a year out now. We're getting a new echo on him, and he's back. He's run 3 marathons since the surgery.
Please, number 4.
Hi, Armando Jester from Boston. So how does the patient's prosthesis choice impact your decision about what kind of repair you're going to expect? Like, you know, does it make a difference that if they want a mechanical valve, don't want a reoperation, the only repair that is acceptable is perfect repair?
Yeah, I think that would make
tissue
it,
valve in a younger patient. Yeah. How do you make that decision?
Well, it might have a little bit of influence on it, but I'm kind of at the stage where I try to think about repairing everything that I think is going to last a reasonable amount of time. And so that's why Dr. Rankin's point is well taken, is we don't really know how much you can really decalcify these valves. Our history with decalcification is not very good. I don't think that's going to play too much into my decision making, actually, to be honest with you.
Well, I just wanted to refer to case number 2. I mean, it is one you were so frustrated about, actually. I'm just trying to figure out whether we can just somehow work on the rules, you know, how to work on with such a situations. For example, you know, one of the claims which was made already is that as long as you have got a flexible, elastic, free edge and not involved by calcification or dysplastic process, and you've got not too much, as Scott just mentioned, just calcium, let's say less than 20%, as long as the free edge is okay, you may just leave it alone, for example. What do you think?
Well, that was the problem, is that I could leave it alone. The only one that might have worked on regarding no residual AI, in other words, just leave the damn thing alone, was the 5th case where there was no AI to begin with. But when most of these cases had +2 to +3 AI. And so we really wanted to make that 0. But I just felt like I couldn't. So you're in that zone between doing nothing, but realizing that the patient's aortic valve was not the reason why they were in the operating room. And that's why it's so frustrating a little bit, because you really want to try to repair those valves, but sometimes you can't. And I would like to hear from the 2 pros here maybe what their situation is regarding kind of mild to minor decalcification at this point in the history of their bicuspid valves, progress.
Yes. Joe, great presentation, and you showed some important cases. We're just reviewing 900-some patients. Calcium came out as a predictor for decreased long-term survival. And if there was more calcium than just limited calcification of the raphe, the probability of having relevant aortic stenosis at 13 to 15 years was 30%. Now, you may say that's 70% of still having a reasonably functioning valve, but we need to keep in mind this calcium appears in some patients and not in every patient. So is calcium maybe an indicator that there is some specific characteristics about the patient that simply make him prone to early development of stenosis? So 10 years ago, I would have repaired probably half of your valves. I've now become more conservative.
All right, well, I think that might be the final word.
Thank you, Joe. We can go to next presentation. Laurent Dekerkov, unexpected complication in valve sparing. That has become interesting now.
Ladies and gentlemen, dear colleagues, it's my pleasure to be here this afternoon with you. Hopefully, a lot of patients have aneurysm AI without any spot of calcification and are very good candidates to repair. I have no conflict of interest in relationship with this presentation. First, before to talk about a lot of awful complications that you want to, of course, avoid in your practice, let's say that valve sparing surgery is first a very safe operation, despite the fact that most of those publications include acute aortic dissection. The rate of hospital mortality is between 0 and 2%, depending on the rate of acute aortic dissection in the series. Also, it is a very durable operation. Dr. David and Magdi Yacoub developed more than 20 years ago now, 30 years ago. And we very well know the follow-up after 10 years, and most of us achieve more than 90% freedom from reoperation after the first decade, and we are analyzing the second decade closely. Also, the valve functioned very well during this first decade and over, with most of the patients remaining with no or mild aortic regurgitation. Very few developed moderate or more. Now, also valve-related events are very favorably compared to Ventricular operation in the sparing. Lower endocarditis, lower bleeding, lower thromboembolic event. But effectively, it's a complex operation of the aortic root, but also of the leaflets. Don't forget, you reduce the diameter of the aortic root, the annulus. You may, not all the time, but you may create cusp prolapse. And you know that if you end up with a cusp prolapse without touching at it, you end up with a very unfavorable configuration, and the risk of recurrence AI is very high. So with the years, most of us have analyzed in their experience what is the good configuration, what is the bad configuration, and we end up now, finally, we know what is a good coaptation. And need to have an effective height of at least 9 millimeters. If you don't have a caliper, this corresponds to the mid-height of the aortic root height. Coaptation length should be more than 4 millimeters. Of course, there should be no residual aortic regurgitation and a good valve mobility. Aortic annulus should be better below 55 millimeters. And that's it. Now, for any kind of surgery, no one, especially if you do a lot of, you have a big activity, no one is immune of complication. So you have to be prepared to that. And I try to compile all the possible complication and pitfall you can encounter in valve sparing surgery here. From the bottom to the top, I include coronary anatomy, root dissection, proximal suture line, commissure reimplantation, distal suture line, and a cusp repair. So many pitfalls, and the best is to know all of them to avoid them. So let's start with the coronary anatomy. Of course, you can have abnormal circumflex or right coronary origin. So it's better to have an angiogram or a coro scan in your patient and to see it. Right coronary artery can raise from the main trunk, and then it crosses behind the commissure. And then if you have to dissect the aortic root, you will have a problem because you will cut it. So it's better to know if the patient presents this feature. Abnormal circumflex artery pass behind, raise from the right coronary ostia and pass behind the aortic root and just at the level where you will place probably proximal suture line stitches. Now, a coronary ostium can be very close to a commissure. So generally you detach the coronary ostium from the commissure, but when it is very close to it, you have to adapt your technique to still do your valve sparing reimplantation, preserving the commissure of the valve. So we leave the coronary ostium attached to the commissure, and we have published a modified reimplantation technique to be able to, in fact, made this procedure in those very specific anatomy. And principally, we leave attached the coronary ostia and we open the graft so the coronary can pass through the graft, and we then close the graft at the proximal suture line at the end, and we make in the graft some sort of keyhole So the coronary is going out of the graft very free. And I will skip a bit of the movie because it's quite long. You see that we close the graft just below, so we keep this annuloplasty effect, characteristic of the valve sparing reimplantation technique, and this is the final result. Now, in short left main, be careful because you may do selective cardioplegia during the anterior procedure if you push your probe too far away. And also, the circumflex can have early departure and can be close to the annulus. And then when you put your proximal suture line, you have to watch out to avoid catching the circumflex artery. We are not recording all our complications, so I cannot show you all of them. But when you have such complications, generally you don't think to record for a future meeting. But I hope to illustrate you the moment of the operation. You have to be aware of the risk of your maneuver. Now, when you reimplant the coronary ostia on the graft, you may induce a kinking of the coronary. And the best is to reimplant it in the appropriate position on the graft. And generally, the main stem, we implant it in the middle of the sinus, of the left sinus, and the right coronary ostia, we implant it on the upper right quadrant of the right sinus. Also, we make our running suture close to the entry of the ostia on the inferior part, so we avoid this kinking that can occur in this, if you put the suture line far from the ostia, and then we go away a bit from the ostia going upward. The more risky coronary is the right coronary, especially if it is small. When we had a problem, generally it was with a small coronary artery. Now, left ventricular outflow tract is what you try to reach to put your annuloplasty. So some of us are making deep root dissection to reach the basal ring, and that's what we are doing. Others prefer to avoid dissection. This is another debate. When you do this deep dissection, generally it's relatively safe if you know where to go. No, there is still a risk for making a hole in the right ventricular outflow tract. Don't be scary by that because it's relatively safely closed with a 4-0 Prolin suture. And before to reimplant the coronary ostia, just fill up the right ventricle and you will see if your closure of this hole is efficient or not, or if you have to add another stitch to have the hemostasis. Now, when you tie the proximal suture line, can it be for a reimplantation procedure or an external ring, the septum is fragile. So even if you put a felt, tie gently so you don't see your felt going through the septum. Now, this is my only slide on the remodeling complication. We are not doing that alone a lot, so I just found in the literature that it's not completely free of complication neither. And when you do remodeling plus annuloplasty, you may, with a suture annuloplasty that was in the early experience when braided suture were used, you may have erosion of the membranous septum and a VSD. I mean, this complication was relatively rare, and when Dr. Schaefer switched for the Gore-Tex suture, this complication was avoided, I guess. Now, false aneurysm due to a tear through the septum, I tell you, with the external ring, this can occur, and also because it passes under coronary artery, you have to be careful because you may have interaction with the left main, and it happened that it caused a problem in some patients. Now, positioning of the commissure is probably the most important step in the valve sparing reimplantation. A commissure reimplantation is never too high. It can be too low with residual prolapse, and this is the case on this echographic image. Generally, we pull as maximum as we can on the commissure without pulling on the graft, and in the remodeling procedure, they do very similarly. We position the commissure at 120 or 180 degrees, and then we adapt the cusp for treating residual prolapse. This is the easiest way to proceed in tricuspid and bicuspid way, and for bicuspid, this is another discussion. Maybe we'll have during other session, but we feel this configuration may be hemodynamically more favorable and with a positive impact on the outcome. Finally, if you use a short graft, replacing only the aortic root, when you do the distal anastomosis, of course, you have to avoid misalignment because you can create a prolapse if you reduce the distance between two commissures. Now, you will have, probably each of us have had that residual AI after a valve sparing procedure. And you have to consider a second run if the AI is greater than 1+. If you have an eccentric AI, it's probably because you have a residual prolapse or an overcorrection of a prolapse. Add or remove a central plication. This is just fine-tuning of the valve repair. So valve exposure is very important, and don't hesitate to control again with a caliper your effective height. Billowing is something we don't like because first the valve has not a good-looking aspect, and it's accompanied by AI sometimes, and then it can be the sign of a low coaptation, and we know that low coaptation is very bad. So if you are sure that it is just because you have very big cusp, but you have no AI and a good effective height and tip of coaptation is high, you may accept some degree of billowing. But otherwise, it's probably the sign of a prolapse, and you may have done a technical error, too small grafts, the commissure are not high enough implanted. Ideally, you should add some effective height to your cusp, adding some plication. Central AI, accept if less than 1 or 1. If more, one option can be to add an annuloplasty, subcommissural annuloplasty inside the valve sparing reimplantation is possible, or remove central plication if you think it is overcorrection. Now, sometimes you have peripheral AI, and that is the sign of a perforation if you have done decalcification or shaving. If it's from a commissure, if it is less than 1, accept it. Otherwise, you can close just the tip of the commissure or close the fenestration, which is responsible by a patch. In bicuspid valve, most of the time it's easy to reach no AI at the end. But the issue here will be to respect valve mobility, especially in asymmetric valve. So if you have an immobile cusp, it's better to remove one plication. Sometimes, it was a very bad idea, I prolongate the plication until the annulus. In fact, this creates a new raphe and it blocked the valve, so I had to remove the portion of the plication that was joining the pre-edge plication, and the annulus. And I gain in mobility a lot. You have different verification tool set. One is visual inspection, which remain very important. The effective height, which can be measured intraoperatively. You can do water test to push the valve in diastolic position. And even people are proposing intra-aortic fibroscopy to check under pressure the aortic valve repair. My conclusion will be that valve sparing surgery is safe and efficient operation. Hospital mortality is very low in most experimented centers. Unexpected outcome and complication hopefully are rare. Most of them are manageable using proper precaution and tool set. Intraoperative transesophageal echocardiography is essential for managing those complications. Finally, best way to avoid complication is to anticipate them and to master the valve sparing technique you have chosen, may it be the remodeling or the reimplantation. Thank you very much.
Well, thank you very much, Laurent. I think you've made all of us aware of what can go wrong, and obviously we'll pay attention to those details. All right. I think that for the sake of time, we'll move on. Next speaker is Joachim Seifers from Hamburg. He will be talking, and probably no one better than him to talk about the need for annuloplasty following aortic valve repair. Thank you.
Thank you for the introduction, and I would like to thank the organizing committee for including me in the program. You've heard annulus, annuloplasty so much here, and it seems everything is clear. It's like in the mitral valve, we believe annular dilatation is a problem and we have to do something and we can all go home. Let me simply utter a word of caution. I would like to go through two components, two thoughts. What is the evidence for annular dilatation leading to failure of aortic valve repair? And second, what is the evidence that annular reduction or stabilization improves repair durability? And I can tell you already, the answer is not as clear as you may believe. Let's first briefly discuss what is the annulus. And here we have a moving target. Anatomically, the annulus is this combined cusp insertion line. This is not the annulus. And functionally, we have a sinotubular junction. We have the aortoventricular junction, that is the transition between muscular tissue and aortic wall. And we have the basal ring, as described and defined by Bob Anderson. For simplicity reasons, I would like to refer to the green line, that is the basal ring, which is a virtual structure, but very important. Let's first come to the evidence for annular dilatation. Let's go through a few apparently easy pieces of evidence. Aortic annulus in this study here from Brussels in patients who had severe or relevant recurrence of regurgitation post-repair was significantly higher. So the annulus is a problem. We also found the same, apparently, published in 2012, valve-preserving surgery, annular diameter was a problem. As you can see here, these patients had poor long-term durability. However, this is an example of a frequently misquoted publication. If you read the text, these patients with the large annuli were almost exclusively treated by reimplantation, and they also had the largest root diameters. And interestingly, there was no difference between remodeling and reimplantation. Long-term, little, if at all, remodeling was somewhat better. And cusp plication seemed to be protective of recurrence of aortic regurgitation. What happened? Keep in mind they had the largest root diameters. So these were the patients that had the largest reductions of intercommissural distance. So they had the highest propensity of induced prolapse by making the root smaller. And you also have to keep in mind, before 2004, we just used eyeballing, and we had no means of objectively assessing valve configuration. More evidence. The Brussels group showed very nicely that annular dilatation can recur after tricuspid aortic valve repair using Cabral stitches, and everything was better once they had done AI increased, and in valve-preserving surgery, everything was much better. However, if you read the fine print of the paper, these were the patients who were operated for only aortic regurgitation. And in this group, there was a relevant proportion which was operated for aneurysm, and they had minor degrees of aortic regurgitation. So in effect, these two groups were not really comparable. We also, in another model, and this was actually an eye-opener to us, saw that annular dilatation could be a risk factor, and these were patients with isolated bicuspid valve repair. So no mixture of root versus valve. So these were all patients who had severe AR as the primary problem. Now, does the annulus play a role? This very nice computer simulation study is probably the best evidence that we currently have. In this study, these engineers from Tel Aviv progressively increased annulus size. And as you can see very nicely, the larger the annulus gets, the less coaptation height we have here. And actually, with annular dilatation alone, there appears a small leak here in the center. To put it into the terms of coaptation height and effective height, the terms that you've heard repeatedly in the last 2 hours, the larger the annulus, the lower effective and coaptation height. So annulus size does have an effect on valve configuration. On the other hand, the papers showing the clinical evidence that this is so clear are not really that clear. Let's come into the second part of this presentation. What is the evidence that annular reduction or stabilization improves repair durability? We can go back into the history of aortic valve repair. This is the first series of aortic valve repair from the 1950s, where at that time the surgeons from Boston did nothing but place an annuloplasty suture at the basal level. Nothing else was done on the aortic valve. At that time, no echocardiography was available, but at least by clinical assessment, it was an effective procedure. Unfortunately, not for a very long time. Is this study indication that stabilization of the annulus is superior? I showed you the slide before. Again, because here in the group with valve-preserving surgery, there was a mix of patients with primary aortic regurgitation and those with primary aneurysm. So it's very difficult to come up with definite conclusion. I would like to show you another study that was published last year. External ring annuloplasty makes everything much better. If you look carefully at the details, you can see here that both extra aortic ring and the introduction of effective height assessment were actually significantly associated with superior results. And it was not possible to distinguish these two effects because at approximately the same time, the surgeons changed from eyeballing to assessment and also introduced this ring concept. Again, we also explored the importance or the effect of annuloplasty, and this has been mentioned before. We published the first results, and actually we saw an effect that was to be expected if we take these computer simulation studies seriously. So whatever we did, whether it was isolated repair or valve-preserving surgery, With annuloplasty, the proportion of completely competent aortic valves was significantly improved, and this at discharge and also at 1 year post-operatively. In the patients who had isolated bicuspid repair, and this we published last year, we could actually see drastic improvement of durability using annuloplasty. So quite apparently, annuloplasty does have an effect on valve, not only on valve form, but also repair durability. And I would like to show you a very recent analysis, which is as yet unpublished. Dr. Matsushima from my team, from Kobe, and currently my team is just working on the results. This is unicuspid repairs, where we could see after introducing annuloplasty for patients with a large annulus, we could significantly improve durability of the repair. Let me summarize. What is the evidence? Annular dilatation reduces coaptation height. It may cause central aortic regurgitation, and because it decreases coaptation height, it definitely increases regurgitation due to cusp pathology. In other terms, if we do an operation, this means that annular dilatation makes the repair result more sensitive to surgical inaccuracy. In other terms, if we do a perfect result, if we do a perfect repair, maybe the annuloplasty is not so important. Perfection, on the other hand, is very difficult to achieve. Annular dilatation contributes to the recurrence of aortic regurgitation after isolated and bicuspid and unicuspid repair. And the evidence that we have from the area of valve-preserving surgery is still somewhat foggy. Annular reduction definitely improves valve competence after valve-preserving surgery, and this is maybe also the reason why in many series, at least the early valve competence results after reimplantation are somewhat better than compared to remodeling without annuloplasty, and why annuloplasty there has a seemingly positive effect. We have not yet seen a positive effect on durability in valve-preserving surgery, but stabilization definitely improves the durability in bicuspid and unicuspid repair, and tricuspid we're still analyzing, and we will have to see the effect. Thank you for your attention.
Congratulations, Joachim, for a nice presentation. And so now in your current practice, you do annuloplasty no matter what, or you're still selective?
Actually, I'm doing annuloplasty in all isolated valve repairs, whatever valve it is. We definitely need it in bicuspid. We definitely need it in unicuspid unless we're dealing with a pediatric patient. In tricuspid, we have not yet seen the effect. On the other hand, this effect may become more apparent within the next 1 to 2 years, so I'm continuing to use it, and then we'll do the analysis.
When you assess the valve, you are happy with your procedure, and then you do the annuloplasty. Then you reassess the valve after, or?
No, the way I do it, and this is the nice thing about the suture annuloplasty, it doesn't distort the aortic root. So actually, I assess my valve, I assess the need for annuloplasty. Whatever annular diameter is 27 and larger will have as a consequence the annuloplasty, and I try to shrink it down depending on body surface area and geometric height to an average of 23. So Joe, you would probably go home with a 25 millimeter annuloplasty if you needed one. Dr. Kunihara here from my team, who's smaller, would maybe go home with a 23 millimeter. Then I do my valve repair, and the annuloplasty is not in the way of the valve repair.
Okay. Any other question?
No, just one comment. So, if I understand what you say, we just have to wait 1 or 2 years, and you will say that we need an annuloplasty in every patient, like we say.
Maybe. Actually, what I'm currently doing to explore You know, for the first 10 years, 10, 15 years, I did not do an annuloplasty, and the long-term results that we've published were largely without annuloplasty, and they were good. So I've now, for roughly 10 years, I've done annuloplasty, 9 years to be exact. I've done annuloplasty almost in every patient, and now we'll go into more thorough analysis to see which subset of patients benefited and which not. In the subsets in which I'm uncertain, and this refers to remodeling, for instance, in bicuspid valve, where it is very easy to achieve perfect valve configuration, I'm now switching. I'm doing the surgical equivalent of a prospective randomized study. That is, I leave it up to the democratic decision of the team whether we do an annuloplasty or not.
So question, so right now you're doing, if you have a 27 or less millimeter annulus for isolated bicuspid valve repair, are you putting in a ring? Are you?
No.
Yeah.
But, and there comes again another
I have to be honest with you, I don't either sometimes.
There is, as Paracelsus said a couple of thousand years ago regarding medication, there is no effective medication without side effects. There is no effective procedure without potential complications. This is why I think a prophylactic annuloplasty is maybe difficult to argue. The point is, and this is another, while I was sitting there and listening to the lectures, I thought I could have brought up another question mark, and this is our definition of annular dilatation. If we just go by echo, and if we just look at the example of bicuspid valves, we largely underestimate the degree of annular dilatation.
Absolutely.
Because in bicuspid valves, it will give you, the echo will give you an annular size of 27, and then you can stick a
31
or 33 Hega inside. So what we need to do is somewhere in this equation agree on a common definition of annular dilatation, which currently we don't have.
Yes.
I cannot hear you.
Yeah, because mic is not working. Now it's working. I think if we are just missing something in terms of preoperative assessment of annulus in bicuspid, it is probably CT. What do you think? Because CT may give us something which we know how useful it is, you know, just watching the TAVI evolution.
I do not fully agree. If we do a 3D, there are a couple of systematic errors. One is there is a difference between annular size on the cardiopleged heart and on the beating heart. And this is a systematic error simply between any imaging and intraoperative determination. Second, the left ventricular outflow tract in diastole usually has an oval shape. So the key question is which diameter do we take, the shorter or the longer? But then it also changes during the cardiac cycle. It becomes circular during systole. Now, these dynamic changes we can assess much better using 3D echo than with a CT, unless we do a CT, an EKG-gated cardiac CT scan, where where we use radiation throughout the whole cycle, and then radiation exposure becomes relevant. So, in effect, I think 3D echo, and this is why I was very happy to hear Michel with the first lecture before the break. 3D echo, I think, is probably the best tool that we can use for imaging and decision making.
Okay, thank you, Joachim. We go on the next speaker, Dr. Girardi from New York. What do we want to achieve to optimize a long-term result of a valve sparing procedure? Leonard?
Thank you, Ruggiero, and thank you to the association for inviting me today. I want to discuss what we want to achieve to optimize the long-term results of a valve-sparing procedure. I have no conflicts of interest to report. One of the reasons that we need to focus on optimizing the long-term results is that because we're performing a lot more of this surgery than we did in the past. Looking at this earlier study from the STS database, where nearly 14,000 aortic root procedures were performed over a 6-year period in the US, we saw that while mechanical composite valve graft remained the most commonly performed procedure, the number of valve sparings doubled in approximately a 6-year period. And this was across a very broad spectrum of centers performing cardiac surgery in the US. Looking at a center more focused on aortic disease, such as ours, we saw that while the mechanical composite valve graft population was way down in numbers, the number of valve sparings became much higher, 30 to 35% of our practice. Now, still dwarfed by the number of biological composite valve grafts performed. As we saw from Dr. Bavaria's presentation, there is a lot of judgment when it comes to deciding who should and shouldn't have a valve sparing procedure, and a lot of our bailout positions when we make those decisions is a biological composite. That being said, though, valve sparing is a significant part of a practice in an aortic center. So whether you believe in reimplantation or you believe in remodeling with or without annular stabilization, the things that we need to achieve to optimize long-term results are obviously safety is most important. It's hard to worry about long-term results if you don't get short-term results. Operative mortality being the primary concern, but of course other problems related to myocardial preservation for these complicated and sometimes long procedures, cerebral protection when we have to add on an arch procedure, and then of course what's the influence of additional procedures that can sometimes be necessary in older populations. The durability, freedom from aortic insufficiency, and of course reoperation. What is the long-term survival? The hemodynamics, we need to try to optimize those. Reimplantation and remodeling, again, for all intents and purposes, currently would be considered equivalent. However, whether we have a straight graft or a Valsalva graft and what are the advantages and disadvantages of maintaining those sinuses remains to be seen. And as we perform more of these and get better at them, are there patients who previously we wouldn't have tried this on, patients with larger roots, severe AI, bicuspid valves, and of course acute type A dissections? Are there expanding pools of patients that we need to try to refine our techniques and use better patient selection to come up with the same type of good outcomes we do in the elective setting? And then finally, the relationship between surgical volume, hospital volume, and outcome is significant, and how should that play into our optimization of the long-term results? Now, we took a look at our results and compared our results with valve sparing surgery and compared them to what would still be considered the gold standard, which would be a composite valve graft replacement. And we looked at both mechanical and composites. We had about 1,200 of these patients, about 25% of which were valve sparing operations. Certainly they were younger patients with many, many fewer comorbidities, a low incidence of coronary revascularization in the past, smaller percentage of hypertensive patients, a lot less reoperations, but a higher percentage of bicuspid valves and connective tissue disorders. And looking at the results with respect to the first and most important question of safety, I think that it is a safe operation without question. We had a 0% mortality, which compared favorably with the composites that we did. The risk of myocardial infarction was very low. Myocardial protection was excellent. We use antegrade, intermittent antegrade, cold blood potassium cardioplegia, and we like that a lot. It protects the right ventricle, which is so important in this operation. The risk of stroke was very low, and the reoperation for bleeding after surgery also very low. Valve sparing surgery is very hemostatic when done properly. Now, the issue of patient selection, yes, they're younger, they have less comorbidities, but I think also when it comes to patient selection, I think you have to pick and choose as to when you're going to push the envelope. Patients who are in need of extensive concomitant procedures, mitral, triple bypass, bad ventricular function, etc. As a general rule, we don't offer valve-sparing surgery to those patients, and we've been very comfortable with the results that we achieve with the biological composite valve graft, particularly so in an older patient population. Others have had similar results. This data from the Cleveland Clinic also showed 0% mortality in nearly 300 patients undergoing valve-sparing surgery, and in their hands, these results compared favorably again with their composite valve graft experience. Now, the durability of these procedures is also quite good. At 5 years after valve-sparing surgery, we saw a very low incidence of the need for reoperation. This compared quite favorably with the biological composites in the early run. Certainly the mechanicals had an advantage. Nobody required any reinterventions within the first 5 years, but nonetheless a very durable procedure at 5 years. And when you look at some of the results from other high-volume centers out to 10 years, the results, again, appear to be very durable. Now, we'll see how it goes in the second decade, but certainly for the first 5 and 10 years, greater than 90 to 95% of these patients can expect a functioning valve and will not need a reoperation in that time period. Survival is excellent. Again, most of these valve-sparing patients are younger, connective tissue disorders. We expect them to do well, and they do. 5-year survival of greater than 97%, certainly much better than a biological composite group, which again, higher incidence of comorbid conditions and certainly an older population. And once again, comparing to others with extensive experience with valve-sparing surgery, very pleased with the results, and the survival is excellent, regardless of whether it's a tri-leaflet valve or a bicuspid valve. Now, the choice of whether a straight graft is adequate or whether a Valsalva graft is necessary is something that previously we were only able to rely on clinical outcomes to assess. But now there are some new tools available that have given us some insight into what might be better. We studied in a small pilot of patients 4D flow MRI, analyzing the flow dynamics in the root following valve-sparing surgery using either a straight or Valsalva graft. 5 patients were done with a Valsalva, 5 with a straight graft. And the Valsalva grafts had significantly less wall shear stress and flow velocity in the aortic root, but their circumferential wall stresses were similar. Flow rotation was also higher in the venous sinus grafts, but most interesting are these vortices that you see down here in the sinuses. And their importance to coronary blood flow remains to be examined in any detail, but certainly this more closely mimics what we see in the native root. So it remains to be seen. The other area of interest is downstream forces following using a straight or a Valsalva graft. Looking at the descending aorta, again, the neosinuses diminish the amount of axial wall stress and circumferential wall stress in the downstream aorta, and perhaps that's going to have some influence on late aortic dissections, particularly on the patients with connective tissue disorders that we so commonly perform valve-sparing operations on. Again, more data needs to be generated. That being said, despite the data at the basic science level or at the physics level, clinically we cannot distinguish between the two grafts. We compared about 225 patients having a straight graft with 101 performed with the Valsalva graft at the European Hospital in Rome. Again, operative outcomes were excellent, no mortality, low risk of myocardial infarction, take back for bleeding rate very low, and at follow-up, we see that there was a very low rate of recurrent significant aortic insufficiency and a very low incidence of the need for reoperation. Now, as we go into the expanded indications, there's a lot of data out there, much smaller numbers, but we have some data that I think makes sense and probably is very applicable to most practices. Questions is, do patients with severe aortic insufficiency achieve a durable result after valve-sparing root replacement? And the group from Belgium, from Brussels, looked at 164 patients undergoing valve-sparing surgery. And about half of those, 57%, had 3+ or greater AI when they went to the operating room. About a third of them were bicuspid valves. Majority of them had surgery with a reimplantation technique, but 25% or so had a remodeling. And half of these patients or more required cusp repair, regardless of whether they had less than 2+ or more than 3+ AI. Again, operative mortality was outstanding, less than 1%. And what they saw was really no difference in long-term durability of the valve. Greater than 90%, actually 89% for those with 3+ or more greater AI, as opposed to 90 to 92% for those with less than 3+ AI. And whether they did a cusp repair or did not do a cusp repair did not have a significant influence on the outcomes. Many others have seen a similar incidence, and so I think in patients with severe aortic insufficiency, where you do an annular stabilization procedure and then most likely do some form of cusp repair, you can get a pretty good and durable result. Now, does the patient with a larger aortic root diameter deserve an opportunity to have a valve-sparing root repair? The group from Hanover looked at 123 patients, excluding those with type A dissections, and broke up the group into 3 separate diameters, those greater than 60 millimeters, those 50 to 60 millimeters, and then those less than 50 millimeters. The mean follow-up was a little over 3 years. The freedom from reoperation was good and was not dependent upon annular diameter. both all around 90 to 95% freedom from reoperation, and the freedom from moderate to severe AI was actually excellent in those with the largest diameter roots. The only reoperation in the group of greater than 60 millimeters was for endocarditis, but not for valve failure. Others, again, have seen similar results. So I think in someone with a large aortic root in an experienced hands, they too can have a valve-sparing repair and expect a good short and long-term outcome. And we've heard a lot about bicuspid valves, both with and without valve-sparing techniques. Isolated bicuspid repairs are a separate issue, but within the realm of valve-sparing surgery, again, a lot of work has been done and a lot more needs to be done looking at these outcomes. One most recent study that is about to come out in the Annals of Thoracic Surgery looked at a small group of 60 patients with bicuspid valve-associated aortopathy at Emory University in Atlanta. Reimplantation techniques were utilized, and a straight tube graft, not a Valsalva graft, was used for a reimplantation valve-sparing operation. They did not, interestingly, they did not follow strict commissural orientation. They did not use a 180-180 or 210-150 configuration that many of us use, instead focusing on just maximizing coaptation with the orientation of their commissures. 85% required cusp repair, primarily plication, and a large number of their patients required arch reconstruction as well. Mean follow-up, again, a little over 3 years. Once again, operative mortality, a very safe operation, 0%. And the freedom from AI at the 3.5 years was greater than 97%, and the need for reoperation was quite low. It did not matter whether the patient with a bicuspid valve came in with more than 2+ AI or not, did not have any long-term effects on outcome. So there too, I think in the right highly selected patients, as you saw from Dr. Bavaria's talk, there are people who you go in with the best of intentions and you find a valve that's not right. But in highly selected patients like this, I think you can get good outcomes. Now, what to do with valve sparing in type A is really, the data is sort of all over the place. And I think that for sure in experienced hands, you can do it and do it well if the patient is the right patient in the right state when they go to the OR. But in a broader respect, if you looked at the outcomes, they're hard to really figure out. Again, if you don't have good short-term outcomes, hard to know what you expect long-term. This is a study from Leipzig looking at 288 patients over a 15-year period, looking at those 288 who had root replacements, Bentals, remodelings, and reimplantations. The operative mortality, as you might expect for a group of very ill patients, was approximately 20%. And that really kind of takes away your ability to assess how well these patients do. Now, the freedom from reoperation was similar regardless of the procedure, but again, very small numbers, very short-term follow-up, hard to really make out what to do with this. There are others like Dr. Shretha's team that does it on a more regular basis. I think, again, with experience, you can do a lot, but when you have an operation with this level of mortality, you have to be very careful for taking on an operation of this magnitude with a level of uncertainty. And finally, to optimize our results, should we consider regionalization of this type of procedure? Again, when you look at that study going back to the STS data in this 2015 paper, the average number of root procedures done at each United States center was 2, and only 5% of the centers reporting to the STS did more than 16 root procedures a year. The mortality for a valve sparing in that setting was 1.9%, and for a composite it was 4.2%. Now, still pretty good and respectable numbers, but not what you could expect in a high volume center. So again, if we're going to optimize the results for our patients, we have to think about what we do, how often we do it, and how much experience we have, plus the system that we work within and the ability to take care of these patients after surgery. So in conclusion, valve sparing is certainly being performed with increasing frequency, and the perioperative outcomes are excellent. So it is a safe procedure with very low morbidity and mortality. The midterm durability at 5 and 10 years appears to be pretty good and certainly rivals that of a biological composite. More data will need to be collected over time. The risk for significant AI without stabilization of the annulus is higher after remodeling, but if you use annular stabilization, the curves seem to be pretty close. But the optimal graft configuration has yet to be identified, straight tube versus Valsalva graft. New analytics will allow us to figure that out over time. The extended indications for valve sparing are growing. Again, more analysis and greater numbers of patients will be necessary, and I think we do have to consider trying to cohort these patients into places that do it often and do it well. Thank you for your attention.
Thank you very much. Congratulations, great presentation. Do we have time for a short comment or question?
Just the single things you can come to your mind just to improve long-term durability. What the things just from where we are now? What
Selection.
Better selection.
I mean, I think the cases that Joe showed were excellent. I mean, they're judgment calls, especially when you're looking at calcified leaflets or fenestrations and things along those lines. I think we have a pretty good idea of what to do with the annulus. When it comes to leaflet, that's where the judgment comes in, and experience of someone like Joachim is what you really need, and you need to do it all the time, which gets back to my point of regionalization. It's a little harder to do in the US. We don't really have that. There's a couple of places that do, but not like it is here in Europe. So I think experience and patient selection are really going to be what helps.
That's always, if you're too selective, few people benefit, like that's... Yes, we have a question.
Yes, please, very
clearly. And microphone number 6.
Yes, thank you very much for your presentation. My question concerns the floor of the sleeve technique, and I have had good results in young adult Marfan patients with perfect aortic valve, tricuspid with no problem, but a dilated root. And it seems to me a technically easy to perform procedure, and I've had satisfactory results over the 2 or 3 years with my very small, maybe 10 patients. Do you see any role for this procedure in this?
Well, I think there's not a lot of data on the floor to sleeve. I mean, even the data from Gainesville, if you look at it carefully on the papers that they've put out, there's not a lot of good echo follow-up in their series. And so I'm not 100% sure what to make of the long-term durability of that operation. Certainly, it's a low-risk operation to perform. But the durability, at least in what I've seen from probably the center doing the most of them, there's not a lot of long-term echo data telling me that it's durable.
Okay, thanks a lot. We have to leave it there. Thanks a lot. So next speaker is Michael Borger. Hi, from Leipzig. So he will be talking about the role for TAVI in this group of patients. Let's see what you have to say.
Should be short.
Yes.
Yeah. Maybe it's a short role.
Yeah, thanks very much. This will be a short presentation. There's not a big role for TAVI for aortic insufficiency. And I also would like to say that David Holzai was supposed to give this presentation. He's my TAVI specialist in Leipzig. But unfortunately, he had to stay because a couple of our surgeons hurt themselves recently. So I forced him to stay and look after the place. Is TAVI an alternative to aortic valve repair? Well, I would say only in very, very select situations. One of the big problems is right now that there are currently no appropriate TAVR devices for pure aortic regurgitation. Previously, we had the Medtronic engager valve and the Jena valve. Unfortunately, the engager valve was completely pulled from the market, and the Jena valve has been temporarily halted, although we always hear rumors that it's going to be released again sometime soon. But these clasp mechanisms that you see on the Jena valve and also on the engager were particularly suitable for patients with AI because they prevented embolization. Can other devices, currently available devices, be used for patients with pure AI? Well, obviously, if they have an enlarged aortic root, then they're not an option. If the aortic root is normal in size, however, then we have to look carefully at the size of the annulus. And if it's more than 25 millimeters, there are no current sufficient devices that can be used without excessive risk of embolization. If they're less than 25 millimeters, then we could use one of these devices, but obviously only in high-risk patients. And as we know, patients presenting with pure AI tend to be younger patients, and therefore this is a very small group that we're talking about. Nonetheless, here's a patient that David did a couple of days ago in our center, 78-year-old female with severe COPD and severe pulmonary hypertension. She did not have any dilatation of the aortic root or the aortic annulus, as you can see here, with a severe aortic insufficiency. We measured the annulus on the cardiac CT as being 23 millimeters, and therefore we chose a Boston Accurate, which is the former Symetes valve, size large, which would give us oversizing. Here are the images from the procedure, and you see the principal problem with aortic insufficiency is that you do not have the calcification of the leaflets and the annulus to serve as your guide for these procedures, making positioning of the device absolutely critical. And of course, we are always concerned about potential embolization. We think maybe with the Boston Accurate device that these stabilization wings in the ascending aorta will prevent against subsequent embolization, and therefore it was chosen in this case, and we got a good result. There is the Boston Lotus valve, which we think is really optimal for this indication because it is fully retrievable. Unfortunately, it was also currently temporarily pulled from the market while they are trying to work out some mechanical problems. Hopefully it should be coming back onto the market again soon. As I said already, the Boston Scientific's Accurate valve, formerly Symetes, has this upper crown for fixation in the ascending aorta and therefore is a feasible option. And then of course you can always use the two workhorses, the Sapien and the core valve or a portico valve as well, but then you have to accept the risk of secondary migration. And therefore the size of the annulus has to be, like I said, 25 millimeters or smaller. What about redo cases after a failed aortic valve repair? I know nobody here has ever seen that on the stage, but I will touch on it just in case. If the valve does fail over time, is a TAVI procedure feasible in one of these patients? Certainly if the mode of failure is aortic stenosis, then you can certainly do a TAVI procedure, although that's unusual. Usually the mode of failure is aortic insufficiency. If the annulus is small enough, if there's been adequate downsizing at the previous operation, or if there's been some reinforcement using either an external prosthesis or an annuloplasty device, then we should be able to place a TAVI without risk of embolization. Of course, you also need to take into account the coronary anatomy, especially if the patient had a previous bicuspid aortic valve, as Lauren has, touched upon earlier. You have to be careful where the coronary ostia is, particularly the right coronary ostia, in relation to the patient's commissures. If a reconstruction is not possible, then of course you could replace the valve with a mechanical valve or a tissue valve, hopefully with an adequate enough size if the patient is young enough to set him up for a future valve-in-valve procedure. But something I would like to just throw out there as another alternative, I'm also a big proponent of aortic valve repair surgery. We do a lot at our center in Leipzig. There's a paper being presented tomorrow, more than 300 David operations, and you'll be happy to know, Leonard, that almost 50 type A dissections, and our mortality rate is now less than 10% in those type A dissection patients. But something that you could suggest, and is certainly, you know, something that is arguable, is rather than doing a complex bicuspid aortic valve repair, even in Jochen Schaefer's hands, who we all agree is one of the best aortic valve surgeons in the world, even in his hands, the bicuspid aortic valve patients have about a 75% freedom from AI rate over time, which is not quite as good as a prosthesis. Maybe we can argue that these patients should undergo a biological aortic valve replacement or biobental with planning for a future TAVI valve-in-valve and subsequent TAVI valve-in-valve-in-valve, particularly since these patients have large aortic annuli, and you can frequently replace the valve with a 27 or a 29 bioprosthetic. Again, I'm a big proponent of aortic valve repair surgery, and I do a lot of it, but this is not completely crazy thinking in these patients, because as we know, the valve-in-valve procedure is straightforward, it's quick, and it's got good results as long as the patient does not have a small aortic valve. What is the option? Well, the option is to do randomized controlled trials. Of course, we don't think that that is going to be done any time in the near future. There is, of course, comparison of retrospective series, which we've been doing for the last 50 years in cardiac surgery and probably for the next 50 years. The problem with that is there's always selection bias, which plays an important role. There's also operator bias as well, surgeon bias. And then the long-term follow-up that we would require may not reflect current practice for these operations. The individual decision, of course, is the way we're currently doing it based on patient's anatomy and the experience of the operator. But like I said, this is something that we may want to throw out there as a discussion point. So in conclusion, TAVI is an alternative for patients with aortic insufficiency in only highly select high-risk patients with suitable anatomy. It may be an alternative for a redo after a failed AV repair, as long as anchoring is feasible and the annulus is not too large. And we may be talking in the future about biological AVR, which is an operation which obviously is a lot more generalizable and can be more easily done by surgeons who are only doing 1 or 2 aortic routes per year with a secondary valve and valve in the future. And this is a concept that I'm sure is going to be brought up more and more as more and more patients get TAVI in the future. Thank you very much.
Okay, thank you very much. Great presentation. Michael has proposed the alternative of...
I think there is in the literature some of these TAVI done in the reimplantation, because with reimplantation, even with remodeling, we have a strong Dacron ring outside that also can compensate for the absence of calcification. What do you think, even with this pressure, high pressure?
To be honest, even in our center, we've done over 6,000 TAVIs at our center. Even at our center, we don't really have any TAVIs post-valve sparing procedure, because they tend to be young patients if they do come back, and we will reoperate on them, and it's not that difficult just replacing the aortic valve. So I don't see that being a big issue.
It's not a big issue, but in some...
But it is technically possible. I know that. I've talked to people that have done it.
Okay.
Okay.
All right.
Can I throw that out here to the panel here? You guys are all a very, very, very select number of surgeons, and I think that biobental followed by TAVI valve and valve is going to be something that will be adopted more generally, rather than the highly technical procedures that we talk about all the time.
Yeah, I agree with you, actually. And, you know, it's just a fact. It's probably going to happen. And you know what? I'll bet you if there was a really well-done prospective randomized trial between those two, it probably would stack up.
Yeah. Should do that.
Yeah,
okay,
like you, I mean, all of these have like equal and larger number of bioband, I'm sure, in their group of patients as well, because they have to select the patient, and each one has many, many bundles and many valve repair, valve sparing.
I'm pretty sure with the low-risk TAVI trials that are coming out, which I'm willing to bet a lot of money that they're going to be non-inferior and they're going to be in New England Journal of Medicine. 5 years down the road, when surgery is superior, it will be published in Journal of... Nobody reads this. But the first one will be in New England Journal of Medicine, and even more TAVIs will be performed. And in a couple of years, there's going to be a lot of people that are going to be doing something like this.
Okay, I think we have to move on. Thank you very much.
Thank you, Michael.
So next is Dr. Comilla. He will be talking about the effect of cusp size on aortic valve repair.
Thank you so much to give me this great chance to present. My topic is about the small cusp size is the limitation for aortic valve repair. I have no declaration of interest. So Dr. Schaeffer's group proposed geometric height for the cusp assessment of cusp size. This is, we can easily measure intraoperatively. Dr. Schaeffer suggests about 16 millimeter for geometric height is a limitation for aortic valve repair. And so this is my aim for the study. There are a few reports regarding geometric height, but for the moment, normal geometric height is not determined. Since 2011, we introduced 4D CT for evaluation of aortic cusp. During endodiastolic phase, we can clearly see the aortic valve. And when there is a prolapse, we can trace the cusp and we can get geometric height even in this configuration. Using this geometric height, we calculate coaptation length before operation. With Pythagoras theorem, for effective height, we preset 8, considering our smaller physics. And the basal annulus and the mean geometric height was substituted into this equation and to get coaptation length. Using this predictive coaptation length, the patients were categorized into 3 groups. Severe annulus cusp mismatch signifies coaptation length less than 2 millimeters. And mild annulus cusp mismatch means coaptation length range from 2 to 4 millimeters. There is no mismatch when the coaptation length is over 4 millimeters. Study cohort consisted of 105 patients. Mean age was 16.7 years old. Type 2 cusp prolapse existed in 51 patients. Our basal annulus management 2 ways. One, root replacement. We preferentially use implantation technique, and the other is basal annulus plication with suture annuloplasty or band annuloplasty. Type 2 cusp prolapse was often observed in right coronary cusps, and repair technique was mainly central plication, and occasionally suspension with Gore-Tex suture was taken. This shows the distribution of geometric height for Japanese patients. The mean geometric height was 17.1 millimeters. There is a strong correlation between geometric height and body height. So consider the Japanese mean body height was 165 centimeters, on contrary German 175 millimeters. So there is a 1.4 millimeter difference regarding mean geometric height. Geometric height was slightly larger in intraoperative measurement. There is a 1.7 millimeter difference between preoperative geometric height and intraoperative geometric height. But the preoperative CT and the postoperative CT, the average geometric height is almost identical. To prolapse collapse, the preoperative CT measurement smaller than non-prolapsed cusp, but intraoperatively the geometric height was almost same. So the patient was categorized into 2 groups according to mean geometric height: smaller group, group S, and this larger cusp, group L. Preoperatively, the patient of the group S was older and smaller in the height, and the annulus was also smaller. Operation procedure for each group: type 2 repair 51% for group S and 47% group L. Root replacement was more taken in group L, and the basal annuloplasty was more in group S. Annular size was reduced post-operatively in both groups, and geometric height in group S larger after surgery, but group L it becomes decreasing. Early mild AR was detected in 51% for the group S and 70% group L. There is a significant difference. During the follow-up, moderate or severe AR developed in 40% in group S and 10% in group L. 2 patients underwent reoperation in the group S. There is a great difference about mismatch. A patient in the group S had 80% severe mismatch, and even after the surgery, 50% have still severe annular scarce mismatch. On the contrary, the patient in group L, severe mismatch is only 20%. So the patients, some patients in the group S, these 3 patients, all female and the short patients, there is no annular scarce mismatch, but most of the patients in group S had annular scarce mismatch. I show one reoperation case. This patient, the average geometric height was only 40 millimeters. During surgery, it seems to be coaptation, but 30 months after the operation, AR became severe, and we have to replace her aortic valve. So let me conclude. Small cusp size is not necessarily contraindication of aortic valve repair. However, in this group, most patients have annular scarce mismatch. Root replacement or secure annular plication to correct annular scarce mismatch is mandatory. Thank you very much for your attention.
Thank you. Very, very nice presentation. And I think that the message is quite clear. It's more the mismatch than the size of the cusp. Which, is there any question? Well, thank you so much. I think we move forward.
The last one. Yes, we call on the podium Dr. Seki from Japan. He will speak on comparison root hemodynamics configuration after valve preserving root replacement in a pulsatile flow mock loop. So experimental setup.
Okay, first I would like to thank the association for the opportunity to present my work. Okay, I have no disclosures. The optimal procedure for valve sparing root replacement still remains controversial. Recent reports show that reimplantation using a graft with sinuses provides better valve behavior. As for remodeling, concomitant annuloplasty procedures are reported to preserve the physiological hemodynamics and annular stability. However, valve behaviors of remodeling with annuloplasty and reimplantation using graft with sinuses have never been compared in detail. So we sought to compare the characteristics of the 2 modern techniques of valve-sparing root replacement, remodeling with annuloplasty and reimplantation with sinuses. We chose the external suture annuloplasty, ESA, for the annuloplasty procedure for its simplicity, reproducibility, and for its excellent clinical results. 2 studies were conducted. First, pulsatile flow simulator study was conducted to compare the hemodynamics. Second, the microcomputed tomography study was conducted to compare the root configuration. Both studies were conducted using tricuspid porcine aortic valve models. 6 models of remodeling and reimplantation with sinuses were prepared from porcine aortic valves. First, the remodeling group was created from the control models, which was the native porcine aortic root. In turn, control models were transformed into remodeling and remodeling with ESA. Tube graft of 24 millimeter was used. Additional ESA was performed for the remodeling models to decrease the root diameter to 22 and 18 millimeters using CV0 Gore-Tex sutures. Control models were prepared for the reimplantation group as well. Then reimplantation was performed using handmade graft with sinuses with the diameter of 24 millimeters. Here's the schematic and the actual picture of the pulsatile flow simulator system. The system consisted of polymer mitral valve and ventricular model with a pneumatic driver, and a high-speed camera was set on the distal side of the valve to assess its motion. The flow was regulated to 5 liters per minute with mean arterial pressure of 100 and heart rate of 70 BPM. Porcine models were attached to the circuit and studied in turn. Hemodynamic parameters assessed were forward flow, regurgitation, leakage, backflow rate, peak and mean pressure gradient as shown in the figure. Backflow rate was defined as retrograde flow divided by forward flow times 100. Pressure gradient was the gap of the left ventricle pressure and aortic pressure. Second, the valve closing time was assessed with the high-speed camera in 2 ways. 1 with the left ventricle pressure assist, and 2 only by visual. Ventricular pressure drop was considered to be the beginning of the valve closure sequence in the former. Here are the results. Remodeling groups are shown in yellow and the reimplantation groups in green. And it is in line as shown previously. First, the forward flow. Additional ESA to 18 millimeter promoted significant reduction in the remodeling group. Significant reduction was also observed after reimplantation. More forward flow was observed for the remodeling compared to the reimplantation, but forward flow between the remodeling with the ESA and the reimplantation was comparable. Next, the retrograde flow parameters. Both the regurgitation and leakage volume tended to reduce after ESA with significance from the control models. ESA 18 group observed significant reduction from the remodeling group as well. Reduction of the both parameters were also observed for the reimplantation group. Compared to the reimplantation, regurgitation was larger in the remodeling and leakage was larger in remodeling and ESA 22. The backflow rate had identical results from the regurgitation volume. Backflow rate tended to reduce after ESA with significance from the control models. ESA 18 observed significant backflow rate reduction from the remodeling as well. Reduction of the backflow rate was also observed for the reimplantation. Compared to the reimplantation, backflow rate was larger in the remodeling. Backflow rate was larger in the backflow rate between the remodeling with ESA and reimplantation was comparable. Peak and mean pressure gradient elevated after additional ESA and reimplantation. Peak pressure gradient was comparable between the ESA groups and reimplantation, while higher mean pressure gradient was observed for the ESA 18 millimeter to the reimplantation. Valve closing time decreased slightly after ESA. However, statistical significance was not observed. To sum up the pulsatile flow study, backflow rate was larger in the remodeling than that of the reimplantation. Additional ESA to remodeling contributed to backflow reduction. However, additional ESA also promoted PG elevation. PG was largest in the remodeling with ESA 18 group with significance from reimplantation. Valve closing time was similar in both techniques. After the pulsatile flow test for each VSRR, micro-CT examination was also conducted to examine the 3-dimensional morphological parameters during valve closure phase. An air pressure of 80 millimeter mercury was applied to the lumen of the models. The measurement was performed in 3 areas, which was the VHA, Valsalva, and ST junction. Diameters were calculated from the cross-sectional parameters. The result shows VHA and Valsalva diameter reduction from the control models in the ESA group and the reimplantation. The ESA groups were both comparable to the reimplantation in terms of VHA diameter. All remodeling groups observed larger diameter for both the Valsalva and the ST junction diameter. To summarize the micro-CT test, VHA diameter in remodeling was larger than that of the reimplantation. ESA reduced the VHA to a predetermined size. Valsalva and the ST junction was significantly larger for remodeling groups than the reimplantation. In conclusion, extensive reduction of the VHA increased pressure gradients. More dilatation of the Valsalva was observed with the remodeling. In general, remodeling with annuloplasty and reimplantation with sinuses were hemodynamically comparable. Thank you for your attention.
Well, thank you very much. Great presentation.
Just a quick question. Did you repeat the experiment varying the size of your graft, either in remodeling or reimplantation, or just use your standardized setup?
We only used the 24 millimeters for this
Just
study. Yes, we didn't change the sizes.
Okay, thank you very much. Any question from the floor? I know it's a little bit late. It has been a long day, but if you have any burning question, Dr. Szczeciński? No? Okay, thank you very much.
Thank you very much.
Thank you. Have a nice day. I thank you all for participating, and see you early tomorrow morning for a continuous meeting. Thank you very much.